make this as user-friendly for everybody as we could, Melissa and I, who are coordinating this class, we're trying to not have anything out of pocket for y'all. So at least if we do it in my office, it's free. If I don't print out a million handouts for everybody, it's free. And for all you who just took boards last week, you just spent a ton of money, so that's exciting to not have to do more stuff, right? So the concept here was, let's slim it down, let's make it easy. Fortunately, the space is a little bit tighter. We reached out to one of the nutritional companies I use, Standard Process, and they hooked us up with some supplies and stuff to just kind of help the process along, so there was no out-of-pocket expense for anybody. If you want water throughout the day, just come grab some. It's gonna be over here hidden, but don't be shy, just get it. If you click this link here, instead of giving everybody printed out handout notes, it should pull up the PowerPoint that I'm going to use today. So, like I said, if you access that, sorry, I'm going to walk in front of you. Tell me once you get it on your phones if you want it there or whatever. But save it to your device or save it wherever you think you want it, that way you have access to it. Because whenever I start pulling it up and moving things around, it's you won't be able to see this screen again. Feel free to get up and move around. Do whatever you need to do, guys.
This is awesome. There we go. Whoops.
Do you need to go get it?
No, it's fine.
Were you able to get it? Alright.
So I'm an airdrop.
Do you have one?
So once you should have a little link at the bottom of your
No,
picture
you're
that opens
Answer
it.
your text message.
No, you're fine. Or do you want another picture?
Sorry, Liz,
Mom,
yes, see where, how do you get picture?
I was doing so good. I got here,
Okay.
and then I skipped over to
Are you
this
recording
chapter.
it or not?
I was like, I gotta read that.
That's okay. That's alright.
There you go.
Stop having
And you
that
should be able to
noise.
download it from here.
I'm sorry, I thought I made another space.
I don't know if it'll open with us. You send it to me.
No, it's downloaded.
Alright, everybody's got it now?
This is great.
Thank you.
This is great.
I'm going to take the screen off, so we're going to go into our real slides now then. Nobody else needs it, correct? Perfect. Alright, so this is us. This is where we're starting. So,
I should have introed you. Sorry.
I did. I'm Chase. Everybody knows me now. Alright, there we go. How many of you, just out of curiosity, are familiar with applied kinesiology or some level of manual muscle testing technique? How many of you have never heard of applied kinesiology or muscle testing technique and you don't know what you're about to get into? How excited. Welcome aboard. So the concept of what we're going to do today is to introduce some basic, standardized, as taught by the Applied Kinesiology, the International College of Applied Kinesiology concepts, and then we're going to just build from there into more elaborate ways of working with someone. But the goal is for you to be able to walk out today, show up on Monday morning in the clinic or the next time you see a patient or something like that, and say, you know what, I learned something cool this weekend. Let me see how it applies to you, specifically patient, so that we can try and get a change in your life. There's like this much information of manual muscle testing stuff that we could go over, and we're going to go over about this much today. Okay, so we're going to try and make it foundational so that it makes sense. You've got some slides to be able to look and see what's going on afterward to kind of refresh yourself. I do have a couple of handouts just because it makes more sense whenever you have it in hand when you start practicing with some people, practicing and everything. But ultimately, the biggest complaint that people have when they start learning applied kinesiology or manual muscle testing techniques is there's so much information and I don't know where to start. So today is hopefully going to give you a step in the right direction of how can we take this concept of patient evaluation and use it with the great skills we already know to be able to help bring someone to a different level of health they weren't achieving before. Okay? Now I recognize that there's a variety of backgrounds in this room today. Some people are classically trained nurses and awesome and saving lives in the hospital system. Some people are in chiropractic school. Some people are office managers that run everybody's lives, who's awesome and amazing. And some people aren't quite sure yet what we're going to do in life, and we're just kind of seeing how things go. And so I'm hopefully not going to overwhelm some of you who don't have quite the foundational concepts of patient management, and not be too slow for everybody else who's like, yeah, I already know everything about neurology. Let's go to the next step, right? So we're going to kind of bounce around between everybody. Because in traditional applied kinesiology concepts, the International College of Applied Kinesiology only teaches to people that have licenses to diagnose. So, to be a professional applied kinesiologist, that means you're a dentist, you're a medical doctor, you're a veterinarian, you're a chiropractor, you're a doctor of physical therapy, something that you can give CPT codes and ICD-10 codes in order to establish a diagnosis and a procedural mechanism of helping them. So the International College of Applied Kinesiology kind of caters to that system of people so that they are using the concepts that are taught in applied kinesiology correctly. And other muscle testing techniques kind of branch from that a little bit. And that's not to say that those other techniques are bad or wrong or anything, but there's a certain standard that the ICAK uses. And we're going to start there before we branch out into some other things, just so we have an idea of where we're going with it. So, this didn't work because I didn't turn it on. Let's try it now. There we go. So the biggest and most important thing when we think about just patient interaction, right? The thing I hope you get out of today is the manual muscle test is a tool to help you, the clinician, do the appropriate thing at the appropriate time in the appropriate manner for the patient. But it does not supersede or override everything else we ever do as clinicians. If someone walks in and I don't know a history, I haven't done a physical exam, I haven't palpated, I haven't done labs, I haven't done whatever I think I need to do to run a clinical workup, and I just grab an arm and start doing whatever I'm doing, I'm potentially missing a lot of stuff. So when we think of manual muscle testing concepts, sometimes we want to jump straight into, let's start testing some things and see what the body has to tell me. But it makes so much more sense with the information you're getting if you know a little bit about that person. So don't be afraid to ask people and measure things and quantify what you're doing, because otherwise you become a technician and you don't become a clinician. And those are very different things. It's super easy to teach someone how to adjust a thoracic spine through a PDA thrust. But it doesn't mean that that person needs it every single time, or that it's the appropriate place or the appropriate time to do it. But if I can do a clinical workup to justify why I'm doing this therapeutic procedure that I'm doing, it now makes more sense. I can now provide care that's beneficial for that individual. So, how might we measure, or how might we find out about people? In my office, we do patient histories and symptom survey forms. Every single person that walks in as a new patient has to fill out about 10 pages worth of paperwork before they ever come back to see me. Why? I'm going to muscle test them, I'm going to do a physical exam, but I want to know information about them. If you're thinking about how you're going to do your clinics in the future, or how you're going to interact with the individuals you see so far, having some level of intake form that gives you a symptomatic expression of who they are is a must. And unfortunately, sometimes we get too excited to just see the person that we forget all those steps at the beginning. I like clinical assessment forms a ton. That's where 4 of the pages of my new patient paperwork are. It's just a symptom evaluation. How is your blood sugar handled? Well, they don't say that. How do you feel after you eat dinner? Do you get tired in the middle of the afternoon? Do you have to urinate frequently in the afternoon? Do you wake up at night to urinate? You know, it's all these types of questions that break down the systems of the body to try and let you know how are their kidney function, how are their thyroid, how are their adrenals, how are things like that going. So I like those questionnaires as a quick way for me to be able to flip through them, get a glimpse of what's going on with the individual, so I have a game plan when I go in and start doing my physical exam. We talked about part 3 and part 4 boards a second ago. When it comes to like physical exam findings, like I do orthopedic-y things on people in my office. I check ACL drawer signs, I check knee valgus and varus testing, I do palpatory things on their stomach, I listen to their heart, I check their blood pressure. I treat them like a real patient because that's what they are, and I like to pretend that I'm a real doctor sometimes too, so I act like that too, right? So I do a little bit of both, and I couple that information in with the information that I'm gathering through non-conventional means, like applied kinesiology evaluations at the same time. I also run a bunch of lab tests, so I run a lot of blood work on people, and I use that information to tell me what's going on with them. Whether that's fancy blood work, like weird in-depth stuff, TMB lymphocyte subsets, or some type of antibody evaluation, or some type of functional assessment like a GI map for stool evaluation, or looking for mold or fungus or yeast, because we all know that that's around everywhere. And you know, how do these things interact with our bodies? And so if we ignore stuff that conventional medicine has, we miss the boat because we're trying to be too awesome and crunchy. But on the other hand, when we're too conventional, we miss the stuff that the crunchy people have to offer too. So there's this balance of how do we manage both sides to get the patient what they need to that they get better, right? And if we can just hopefully hone in on that a little bit, even though we might all do it differently in our future. It allows us the best case scenario of helping the individual that's on the table at that time to get where they need to be. So, when we think about how do we approach health, each one of us is going to have a different hierarchy of where we assign our most important thing, right? For some people, like in this particular one that I found off Google, they like the foundation of being mindful, having a good positive outlook, a good stable diet, a clean environment, exercising, resting, and having fun. And that's the foundation of life that then builds into something like having stable blood sugar, improving their digestion, supporting their adrenals, supporting their thyroid, supporting their hormonal system, and then looking at other organs and glands in the body. That's the approach they choose to take. Is that a right approach? Is it a wrong approach? Yes. But no. Because each person is going to be a little bit different, right? When I look at people, I have a specific foundation or hierarchy in which I address first. And if you're anemic, or you have a blood sugar problem, or you have a thyroid problem, that overrides every single thing that you've got going on in your body relative to how I view things. So if someone comes in and they are in a car wreck, and I do a blood test on them, and they're anemic, I fully expect their anemia to prevent their car wreck symptoms from getting better. Because that's a big deal if you're hypoxic and you don't have oxygen delivered to your muscles or your tissues or things like that. So therefore, I will spend time talking to this car wreck person about anemia and supporting them nutritionally and dietarily and whatever so that they can get better even though they just want me to crack their neck because I'm a chiropractor. Does that make sense? Like there's a balance in that world. This other one here just happens to have a different version. They propose that disease starts with digestion, and if you don't detox or blood sugar or stress or whatever, and then eventually comes up, and as you balance everything out, then you have health stuff. Obviously, this paradigm is going to be different than others. Like genes is their least important thing. But how many of us have talked about getting gene tested for whatever and having invasive surgeries or doing therapeutic things based off what our genes say? We hear people talk about it without ever saying like, well, maybe what I'm eating is jacking up my genes or what I'm living in or how my immune system is handling things, right? So different people have different things, right? This here is another concept. You've heard the triad of health. I don't know how they teach things at TCC. I graduated from life, so I don't know what y'all learn. But the triad of health obviously is a concept that has foundations in chiropractic-y things, 3D power. And this is kind of expanded triad of health. We think of structural, chemical, and nutritional balance. And if you have a perfect triangle, then you're probably healthy. And these other words on the outside are kind of like subcategories of these things. So structural stuff could be like chiropractic and osteopathic stuff, or dentistry, or muscle techniques, or whatever. Whereas some of these emotional stuff or mental things could be homeopathy or whatever it might be, right? So this idea of balance can be manifest in different ways, and that's going to be different for every one of us, right? Like me personally, I'd love to live in the structural and nutritional world or chemical world. I don't really go into the emotional world a ton. I do sometimes. But because I don't do a lot of things over here, I hired a super awesome lady who knows how to do it better, and I just like, hey, you got some stuff showing up? Go see this person. She's better at it than I am, right? So I recognize where I'm really good, exceptionally good, you might say. No, I'm just joking. where I do good things, and then where I lack, and I just try and fill in those gaps, recognizing that there's other parts of the paradigm that I'm not super efficient at. Does that make sense? This one here is kind of a process here that builds, this is the official ICAK, International College of Applied Kinesiology logo. And this logo means something to people who practice applied kinesiology, because you've got the triad of health that we think about. We've got the body and the spine that kind of is manifest here. But then these different letters represent different things that might cause muscular imbalance or neurologic tone issues that affect muscle function in the body. So for example, if I start doing my applied kinesiology exam and I find a weak muscle, and I think that shouldn't be weak, we expect muscles to be strong, so why does this person have a weakness somewhere? I could look at the nutritional or neurologic side of the body, the neurolymphatics, the neurovasculars, the cerebral spinal fluid, or the acupuncture meridian connectors. And so applied kinesiology couples things like SOT with acupuncture, with nutrition and neurology, with viscerosomatic reflexes, and things like that. And when I see a patient present and I start doing my manual muscle testing evaluation, if something gets off, not only do I look at chemical, structural, or emotional things, but I'll subcategorize into other areas to see how I might support that individual. And I know that sounds weird right now because we haven't gotten into how we actually do this, but the concept is paradigms. The cool thing is every single one of you is going to have an opportunity to interact with the individuals you serve under the paradigm in which you live. And as long as you have a foundation in which you can go into each person and evaluate them with, you will have a concept where you can say, you know what, I don't know what to do, but I know where I can start. And you just start working on them and getting them better, and things happen. It's awesome. You'll love it. Clinical processes are great. So, I wasn't sure who was coming today, like your backgrounds. So I put this link here in case you want to nerd out on the neurology of how manual muscle testing works in the body. Find this slide, go read this 20-page paper, and you'll recognize what the peer-reviewed literature is stating on what we claim that we do in the International College of Applied Kinesiology. The most neurologically sound basis for why we do what we do. And it has to do with spinal columns, anterior motor neurons, muscle responses, all kinds of weird stuff that people in neurology like. If you don't care about that and you're just like, dude, show me how to fix someone's parasite, then we'll get there eventually. But this concept is cool if you like reading about stuff like that. And this is part 2. Part 1 is also good, but part 2 is where this guy here, who's an applied kinesiologist, takes it into more clinical setting and application. This is actually the guy I learned applied kinesiology from. He's not here anymore, but he was amazing. Wally Schmidt, if you ever hear about him later. So, we're going to start with a concept though. And that is afferent-based evaluations. In neurology, we have two main pathways. Well, two main systems of communication. If the brain sends the message down and tells the body to do something, we would call that what? Efferent, right? Easy. If the body tells the brain something, we call that afferent. So we're going to look at this concept of afferent-based receptors as part of our physical exam, and we'll just start there because that's the easiest thing to do. Does anyone happen to know if they have neck pain that creates restriction of motion, or shoulder pain that creates restriction of motion, something that creates restriction of motion in their body?
Does somebody have that
Yeah,
in here? I
sure.
do. I've got a.
Cool, come over here. Come have a seat right here. If you don't mind being a guinea pig, they're going to record you here because that's what they do sometimes. You're going to sit here facing this way.
Okay.
All right. So let's pretend Leslie comes in and she's doing a new patient visit in my office. And I've already done my history and I've already talked to her. She's filled out 400 pages of paperwork and all these things. And I'm now to the point where I want to do something to see what is she really capable of doing. Well, we saw earlier that the concept is measure, measure, measure. Whether I'm measuring on questionnaires or I'm measuring through range of motion or I'm measuring through something, I hopefully am not justifying what I'm doing because an arm went weak or a leg went weak. I need to know more about the person. So just out of curiosity, where does it hurt in your life?
Right here.
Right there. Okay. Is there something you do that makes it worse and make it hurt worse?
Sleeping, turning to the left.
Okay, so let's have you sit straight and tall.
Okay.
I'm standing right here, more or less in the middle. Turn all the way to your right. That doesn't hurt anything.
No.
Can you see my shoulder?
Yes.
Okay, turn all the way to the left. Does that hurt anything?
It's starting to, yes.
Starts to hurt. Can you see my shoulder?
Barely.
Barely. Do you see my shoulder less over here than you do over here?
Correct.
Okay. We have a baseline measurement, right? So let me just introduce a concept which is through digital contact, manual palpation, touching somebody, we might be able to create an afferent change which might change restrictions, pain, or decreased function, right? So if someone's going to turn this way, just out of curiosity, what bones might move a lot?
Cervical nerve.
Okay. One more than another? Which section of the segment of the upper spine or the neck are going to move the most? C1, C2, right? So all I'm going to do is I'm just going to take digital contact, and I'm just going to gently pull the spinous process of C2 over, and we're just going to see what happens. It'll be an experiment for all of us. Okay, turn left. Does that hurt less?
Yeah.
Does it move more?
Yeah.
Crazy, right? Okay, go ahead and relax.
Okay.
Now, was that any weird stuff or witchcraft? No. It was an afferent provocation, and I attempted to provide sensory input into the body. Could I do something like this in clinic without getting in trouble?
Yes.
Yeah, super easy, right? Turn this way again without me touching. It's already doing better than what it was. And I did nothing but just gently pull that spinous process over, right? Now, what if, hypothetically, she had a shoulder and she goes to raise it up and she goes, ow, that hurts right there. What might I attempt to do? Well, if nerves come from the neck and go down and tell muscles what to do, I might attempt the same thing. What major nerve goes to that deltoid muscle. Boards people. C5, right? So I might grab the C5 vertebrae and just slide it over. And let's pretend she goes and it makes no change at all. Does that mean this is a failure of technique and it should never be used again? No, it just means what I attempted to do didn't help her. So I should attempt to do something different, right? So maybe I grab that C5 bone and I move it the other direction. And I have her test it out again and she goes, nope, still doesn't work. I'm like, well, that's weird. It went left and right and didn't change anything. What if I pull it back or forward, right? So maybe I grab the front and I have her do this and she goes, oh my gosh, I can move so much better than I used to. I just used an afferent challenge on the body by doing nothing more than gentle mobilization at the same time we tried an activity. Have any of you ever done that before? Have you ever seen that like in class or whatever? They don't talk about this? No. It will blow your patients' minds. If you don't see patients, it'll blow whoever's mind you just do it to at the bar whenever you're like, watch this, right? No, I'm just kidding. So what will happen though is it gives me feedback. When I say turn all the way this way and she says it hurts and I can't, and then I just gently push on her C2 and have her turn and it makes it better, I might think, all right, I'm going to set that bone later. What else can I do in the meantime, right? But what if I go through and I push on everything and it doesn't change? That only tells me that whatever I've attempted so far isn't the solution and there might be something else. Remember when we go back to this concept of applied kinesiology, I look at nerves and nutrition, I look at vessels and lymphatics, I look at craniosacral type things, and I look at acupuncture things, I look at nutritional things, I look at emotional things, and I look at other structural things. So I look at a variety of things when someone says, I can't turn left, and the easy thing for me is to start with the spine, because that's just easy. Sorry, we're giving side eyes to my daughter. Hit the camera. No, I'm just joking. She's doing great. So things like that, right? So we might look for a way to provoke the body instead of just saying, oh, look at your x-ray. You're fine. You don't have a fracture. Your neck hurts to the left. Let's just crack it up. We'll see you 3 times a week for the next 6 weeks, right? Love it for the pocketbook. Super inefficient for patient management, right? So we're trying to see how can we create change for the individual. So in a bit, we'll experiment and practice with this because today is not me to talk to you for 8 hours. It's I've got 4 treatment rooms and a bunch of tables and we'll get up and we'll go meet people that we don't know and we'll test things out and we'll see what works and what doesn't. So we can start off with basic range of motion. Stand up for me. Stand right here for me, facing that direction. Just like that. Like that.
Okay.
Go down, touch your toes for me. That was too efficient. You did great.
Oh.
So that was great. So no issues there, right? She had great range of motion. She touched the floor. No problem, right? Let's just pretend when she did that, that hurt. What might I think in my brain, because we're learning to think today, what might I do to try and change that and see if I can make a positive impact in her life? Well, throw it out there. What do you got? What might you just jab on? Because we saw the neck rotation was messing with the bone. Well, let's pretend she couldn't do this.
Would you address the SI?
Yeah, that's a great place to start, right? So maybe I take a thumb and I grab this dimple right over here and I just jab on it and I'd say, now go down. And I'd say, oh, is that same, better, or worse? And she'd say, oh, it's same, better, or worse, right? She'd answer whatever she answers. And maybe that doesn't help. So maybe I come to the other SI joint and I just gently jab on it. And then she's like, oh my gosh, I can now put palms on the hand instead of just my fingertips. Even though it didn't hurt. We're going to play with this in a second, so don't be afraid to touch people and get to know each other really well. You crushed it today. Thank you very much.
Oh.
So, afferent-based system. Any of y'all ever heard of activator technique? Any of you ever studied how to do it? No? Do they don't teach it in school there?
Yeah, they do.
Very little.
We have a survey.
Very little. They use a leg length check. They have you do things, and they attempt to look for leg length variations. That's an afferent receptor challenge. If I'm laying flat on the ground and my legs are straight, and I turn my head and my leg shifts, is it possible that I've given the brain feedback and it's compensating somewhere else? That's the theory behind that, right? If you ever did like Ted Korn stuff, he does the same thing with occipital lifting. SOT challenges in sacro-occipital stuff is we're looking for sensory input. Motion palpation does a little bit of this, right? So some concepts that we may have heard of or been familiar with a little bit, and like I said, I don't know TCC's schedule and how they do things, but that's one way of looking at range of motion, and I guarantee you, if you start doing this with people in the office or people you meet, you're going to see like, oh my gosh, it hurts, but what if I jab here? Oh my gosh, that's crazy. And it's a big deal. Changes your lives.
Yeah.
She's gonna go home and tell her friends about this. She might even post it on Facebook and tag me.
I've had this crick for weeks.
And I didn't even crack your neck yet.
I know.
So that's exciting. Good for you.
Yeah.
Glad we could do that. Thanks for being a guinea pig. All right, so that's one thing I'll do on everybody. If they come in with pain, I will ask for a range of motion around where they're at, because that's what we should do as clinicians. And then we will attempt to see if there's something I can do likely that creates change, and then I just make note of it. C2 on her left might be a big deal in the future. SI joint on the right might be a big deal in the future. And you just make some notes so that you can play doctor later, right? So now, there are other things that I do. And we're going to introduce this as our starting point of weirdness, because this is something that most people aren't familiar with. So, Chapman's reflexes were discovered by a guy in the 30s who was an osteopath, and he basically proposes that there are certain places on the body where viscerosomatic reflexes are more manifest. Now, a viscerosomatic reflex is where the organ creates pain or discomfort on the superficial or external part of the body. How many of you have ever heard of a heart attack? Raise your hand. Good. How many of you know where you would experience discomfort if you had a heart attack? Left arm, right? So somewhere on the arm is going to hurt when your heart explodes. Why?
Excellent question.
Viscerosomatic reflex.
Viscerosomatic, the organ and the nerve that comes from the brain down the spine to the heart shares a connection, a shared connection with that arm. So when the organ blows up, the body says, I don't have good enough I don't have good enough topographic awareness of that organ, so let me use the rest of the neurologic chain to tell you that you're about to die. Right? And so it does that. What about if you had gallbladder problems? Where might you feel that? Well, two places. You can feel it locally to the area because your gallbladder is exploding, or you're going to probably feel it up in the shoulder, the opposite side, and in the neck. So some people will come into the chiropractor and say, oh my gosh, I've got this recurrent neck problem right here over and over and over again. The chiropractor's doing an amazing job of setting bones and moving stuff. But nobody ever thinks, maybe their gallbladder sucks and they just don't know how to metabolize fats. And if I can put them on a supplement or change their diet or do something, now all of a sudden this goes away. Love seeing them 3 times a week for 6 weeks, but they had a different problem that was manifest in other places. What about like prostate pain? Where'd you feel that?
Lower back.
Low back.
Maybe.
Guess that's not
Not the answer I was looking for. Anybody else have a thought? If you have prostatitis, you're probably going to feel it on both sides of the heels. It's a shared connection between the prostate and the lower extremity muscles and bones and tendons. You know, it's just like a tree that has branches. And one of those branches goes to the prostate, and one goes all the way down to the feet. And so when they have heel pain on both sides, I think immediately, their prostate's about to do wonky things, right? Now, is this like that all the time for every person? No. But it's a good starting place, right? That's why we read textbooks and learn things. So Chapman figured this out. And so he started jabbing around on people, palpating, the medical term for touching people, right? So he was touching people in specific ways, trying to look to see what had pain and what didn't, and correlating that with his symptoms, or their symptoms, and what didn't. And he came up with a system of Chapman's reflexes. So we're going to go through some of them. And this is going to be moderately overwhelming, which is why you have your own slides in front of you. But we're going to demo somebody. I need someone who I've never touched before. Never palpated. Can someone be a guinea pig? Anybody? Come on up, buddy. You're doing great. So we're going to have you put your head here. No, we're not. We're going to put your head here and your feet here. So head here, feet here, on your back, just like this. So let's pretend. Remind me your name again? Jeremy. Let's pretend Jeremy comes in. I have 10 pages of paperwork on him. He's filled out a million questionnaires. I've done some range of motion checks based off of whatever pain he might be having or not having. And now he tells me, fix me. It doesn't even matter what it is. I will start with this type of palpatory exam, whether they're here because of low back pain, or because they've got toenail fungus, or because they only poop once a week, or whatever it is. I don't care. I'm going to start here because I want to know about this individual. And unfortunately, he may not have gone through medical school and may not know what's going on with him. So therefore, he comes in and says, I have, hypothetically, lower right neck and shoulder pain. Well, I just learned that that could be a gallbladder issue. So I might want to look at his gallbladder, or I might just look at his neck structurally. But I like to do both, so I look at both. So I'll have him start, and I'll just do this. Take your hands like this. Bend your knees. I'm going to touch you. It shouldn't hurt. If it hurts, please let me know. Some variant of that conversation happens. And then I should start touching specific areas through vigorous palpatory approaches, right? If I touch like this, does this hurt? 0 out of 10 pain? 0 out of 10 pain? 0 out of 10. 0 out of 10. So therefore, we have a way of knowing that he doesn't hurt when I jab on certain places. So what if hypothetically I jab on this spot and he goes, ooh, 4 out of 10 pain? Is that assuming I'm the doctor doing things equally means I might have found something that means something to me. So there are different spots where we think of viscerosomatic reflexes. They might manifest as a Chapman's reflex, and one might be for pancreatic activity, or let me rephrase that. For enzyme creation activity is what I really mean to say. So if I come over here and on his right side, coming down his rib cage, I just gently poke on him like we were done before. Is there any pain when I do that?
There's a little pain right here.
More than this?
Mm-hmm.
Tell me, right there? So on a scale of 1 to 10, 10 being the worst, what is that like?
3.
3. He's gonna watch out. No, I'm just joking. Obviously not, right? We know nothing about what is going on. Other than he said there's pain there. What could cause pain there?
Stomach thing.
Possibly an enzyme issue.
Liver, gallbladder.
Possibly a liver gallbladder issue. Possibly a hiatal hernia. Possibly a rib out of place. Possibly did bench yesterday and his chest is sore. That one test tells me nothing. Which is why I need a history, an exam, and more information about someone, right? That would be so silly for me to now perform surgery because it hurt right here. And say, oh, your pancreas sucks, we're taking it out. Right? Obviously that makes sense. But sometimes we make clinical decisions because we're like, well, I'm sorry, your arm went down, you must have a parasite. Or, I'm sorry, your neck felt lumpy on this side, it must be out of whack, let me crack it. Or whatever, right? We make decisions based off of individual things sometimes. So we've got a 3 out of 10 over here. Chapman would propose that certain reflexes manifest in certain areas and could lead to certain pain, right? So we just happen to hit the enzyme point here. We're going to do another one. Oh, that's the wrong direction. Here's another one for a different enzyme. And I'm just going to go to the other side of the body. So when I jab on this side of the ribs on a scale of 1 to 10, any pain or discomfort there?
It's about the same.
About the
same point.
but right about the top?
Mm-hmm.
All right, so that's interesting. 3 over here, 3 over here, but nothing down here lower. All right, cool. We're just getting data. 3 and 3 on both sides of the top of the ribs. This one tends to lead toward hydrochloric acid related production. Does that mean that this is pathognomonic or every single time? No, but it's a place to start, right? We're just touching. We're getting to know each other a little bit. We've all done a gallbladder sign or a Murphy sign where I hook my fingers under his ribs. Any pain or discomfort there? Take a deep breath in and then out. No pain or discomfort.
There was some.
But I mean, like, real pain or discomfort, just like because my fingers were 3 inches up your ribs.
And
Nothing
it wasn't like this.
So less than 3, but nothing too crazy. Okay. Probably not a big deal, right? Another sign, similar thing, but for the spleen. We can come over to the other side. Nothing too bad, right? And don't be afraid to touch people. You're clinicians. This is what you do, right?
It was worse on this side than that side.
Okay, so 3, 3, 1, 2, 0 ish. Is this too fast? Is this good enough? Because y'all are going to go practice this in a second. Like I said, I've got 4 tables. You're going to all get together with partners. You're going to jab on each other and then see what happens. If you don't know where body parts are, just guess. Just, I don't know what happens when I jab here. Like, right? It's like, oh, your belly button. Let me just kind of poke around a little bit there. Any pain or discomfort? So no problem. Good. We'll go to another spot. Large intestines kind of go around the small intestines, so we'll kind of jab on those. Nothing too crazy. Good. Doing great. I'm going to jab really deeply into the corners. All right, so we're going to come deep here. Nothing too bad for your ileocecal valve, or your Houston's valve, or sigmoid colon. Okay. You have ovaries? I gotta ask that. I'm just joking. So, hypothetically speaking, I'd come right into the middle, and I'd jab deeply right in the middle, and push down like I'm trying to poke an ovary. You have breasts? You do. Men have breasts as well. They have tissue in that area. Men get breast cancer, so I'm going to jab on you also. Let's pretend this wasn't a man. Okay, I'm going to touch you in your chest real quick. Right? I don't want people thinking I'm coming in for a good time. So I have to remind them and say, hey, I'm going to jab you on the chest a little bit. And you'll notice my fingers are up like this. I'm not like this, right? Because that gets uncomfortable. No pain, no discomfort? Good. I'll jab on sinuses. I'm going to jab you in the face for a little bit. Any pain or discomfort when I do this? Any pain or discomfort when I do this?
No.
Easy so far, right? So now what? Who cares? He's here for neck problems, and I just jabbed all over his body. What does that actually tell me?
Nothing yet.
Nothing yet, but it could. It tells me that he felt some level of discomfort in a couple of areas, mostly in this region here. And so now I can play around and do something, right? In a second, I'm going to pass out this little sheet for you, because each of these points correlates with potential nutritional intervention that could help them. Because if he has enzymatic insufficiency, whether through the pancreas or through the stomach, and that's what's causing some of his discomfort here when I jab on him, but leading toward compensatory discomfort elsewhere, then maybe I just need to support him with some enzymes. So I told y'all earlier that Standard Process hooked us up with some things. Excuse me? No, tell me. You run my life. What's up?
I just didn't know if you wanted me to open those.
Oh, no, it's fine. I'm going to open these. So we're talking about this concept of helping out and doing things, right? So if I have an afferent stimulus, a sensory-based stimulus into his body, I could potentially try and make a change, right? We saw with touching someone's neck, it created a change. Well, how do I create change with his potential enzyme or hydrochloric acid issues? I could just give him a supplement and say, here, take this for a month and we'll see what happens. But I like to wow people as well as make sure I'm doing the right thing for him. So I do oral gustatory challenges through the afferent system. Do you have any allergens or need to be kosher or halal or anything that matters? Nothing like that. Good. Put that in your mouth for me then. Now, it's funny, we laugh sometimes about this, but like, what if he's Muslim and doesn't eat pork, or Jewish, right? There's probably pork in this. So I don't want to give somebody something that they don't want to do in their life. But what I grabbed is something called AF beta food, and I picked AF beta food because of the things that are on the list here that we could draw from, but also because it tends to help with carbohydrate metabolism, liver metabolism, something like that. Does that mean you can only use these companies? No, not at all. I like them. I use a bunch of them as evidence up by my shelves, but it's a place to start. So we're creating a challenge. His taste buds are tasting something and telling his brain, I've got some beets, I've got some carrots, I've got some liver. Tastes great, right? Not too bad. And I just want to see, did I create change? Earlier this was a 3 out of 10. Is that still a 3 out of 10?
No.
No way. Were you a paid person to come up here and tell me this? What is it like on a scale of 1 to 10?
It's like a 1.
1. So we got a 66% improvement with that thing on his tongue on one side. What about this side?
Like a 2.
2. So only a 33% improvement on there. So that's not good enough for my books. What about if I come under, deep breath in? No. Is that still like a 1 like before? Alright, so that didn't change under here, but it made some level of change in one of them. Would I potentially give this to somebody? Maybe. It was very kind. Just that trash can over here. There's a small one. Keep enjoying that for a bit. No, you can spit that out in this box if you want.
Come on.
You good? Well, let me just spit it out actually. Because we're doing more fun things. Thank you. Alright, thank you. Alright, so wait a second. We just did afferent sensory input, creating a viscerosomatic change, potentially saving his life. Probably not. But at least helping him digest some things a little bit better, right? Does that mean that's what he needs? I don't know yet. It's just a data point. It's just one more plot on the chart that says, maybe I'm going to do this to him, maybe I'm not. What does his history tell me? What do his labs tell me? What does his physical exam tell me? Whatever, right? So we saw AF beta food made one change a lot, one change some, and one not change at all. Because I like to wow people, I will look at something different. So I'll grab a different one here. This is called Diaplex. And Diaplex is often used for blood sugar related things and supporting insulin and pancreatic activity. AF beta food, like I said, is used for blood sugar things, but helps with the liver and the gallbladder some more. So this one, just place that in your mouth for me. The cool thing about our brains is they pick up on what we put on our tongue. And kind of like if you had a peanut allergy, how long would it take you to react to that peanut?
Not
Pretty
nice.
Pretty instantly, right? but why? They didn't chew it, they didn't digest it, they didn't assimilate it, they didn't process all those micronutrients. But the body is pretty intelligent, and it says, we're gonna kill you now, right? And so we don't eat peanuts if we have a peanut allergy. Well, we're doing the same concept, but in reverse. I found something palpatorily speaking that's not working right. I'm putting it on his tongue. I'm looking for afferent change. Is that still a 3? What is it like now?
It's,
Like this?
yeah.
0 is the correct answer. And this side over here? Sorry, I'm just messing with you. What is that like?
Like a 2.
Like a 2. So that one still is about the same. A little bit better than beta food, but still about the same. Same. All right. It's getting closer and closer to gallbladder removal surgery. Right? We're not going to figure out what it really is. But that's how we can demo this process. So, I've got rooms, and we've got some stuff to play with. Go jab on each other. Here's a quick reference sheet. The first page is the one that we're looking at here. Oh, go ahead and set it for me. You did great. Crush it. So take that, take a packet and pass it on. So what we're going to do is we're going to get in a small group, get in a partner, give us someone you don't know, it's perfectly fine. You're going to go and jab on some of these spots. If something hurts, make note of it. Come see if we have a product that is in that category on our little system here. So there's 4 rooms, okay? The very back room over on the left doesn't have very many supplements that are open inside of there. But there's a table, so go use it and play around with it. The next room doesn't have a table in it to use. The third room is my room, and there's like 20 different pills open in that room. So just grab whatever you want and start playing with it. If it's not on the list, it's fine. And then the last one also has a table, but there's nothing open there. And then there's this one. So then we got 4 tables. Go pick a table and go start playing around. And we're going to take a little bit of time to just jab and go through this concept of what is range of motion looking like? What is palpation doing to me? Does a nutrient challenge, when I put it on the tongue, make a change? Sound good? Anybody have questions so far?
I'm gonna hit the restroom first.
Good. Restrooms are down in front of the stairwell if you need them. There's more water down here. We'll go from there. You can go. Thanks. Cool. Ready, break.
Studying a nutrition degree. Trying to do both things.
What's your name?
Liz.
Okay.
All right. There you go. Anybody find anything fun? Raise your hand if you saw something cool in your room.
That's pretty cool.
Anybody have something super crazy where it's like 9 out of 10 pain goes to 0? Nothing that extreme? When you do that with people, it blows them away.
It does.
They walk in and they're like, don't even touch me there. You're looking at it, it hurts. And then you put something on their tongue and they're like, oh my gosh, how'd that happen? And they're looking for it, it's crazy. So, neat parlor trick. But more than anything, it helps you get clinical information to help somebody, right? Cool. Did any of you have a range of motion thing or a non-nutrition exam thing that you tried out and saw? Like, you couldn't turn your head one way or the other? What happened in y'all's group?
My neck was tight on the left side, and like when I would turn that way, it was pretty tight. And then she like pressed on it, and she pressed on it in a couple places, and then it feels a good bit better.
Isn't that crazy?
Mm-hmm.
So sometimes even just slight touch, bringing up neurologic awareness, allows things to start changing. Now, full disclosure, if you've got a bone out of whack and it hasn't really been put back into place, that may only last 5 minutes, 10 minutes, 30 minutes, who knows, right? But on the other hand, if you've got something going on that, is messed up and you move it and it gets put into place and it stays there for a while, then she changed your life. Does that make sense? Good stuff.
Mm-hmm.
Now, what I didn't demonstrate, but you could consider, let's pretend, you said you had neck rotation stiffness with pain? You still have it right now?
A little bit. I mean, there's.
Come have a seat for a second. Let's just see if something changes for a second. Let's see it facing that direction. So, I'm going to sit right behind you, sit straight and tall. If I have you turn all the way this way, does that hurt anything?
No,
Can you see my shoulder?
barely.
Barely. Okay. Turn all the way this way. Does that hurt anything?
It starts to pull.
Okay. Can you see my shoulder?
No.
Can y'all see a difference in her range of motion?
Yes.
Okay. Now, we talked earlier that I might be able to therapy localize or touch something and try and get it to change. We're going to experiment and just think out the box for a second, because we saw that when I poked on stuff, it might hurt. I can put something on her tongue and make a change. Is it plausible that if she has a range of motion issue and I put something on her tongue and change the afferent system back into her brain, it might make a shift as well? We didn't talk about it in our demo, but let's try it because we're thinking outside the box now, right? Just out of curiosity, let's try AF beta food. Put that on your tongue. AF beta food is my 7-year-old's favorite supplement. Every night, he asks if he can go get some AF beta food, and he'll go in there and I'll say, yeah, you can get 1 or 2. And he'll come back with 5 or 6, and he just throws them in his mouth and chews them up, and he thinks they're delicious. So all of you who are grimacing for AF beta food with the liver and the beets and the carrots that are in there, suck it up.
That's his treat when he comes to the office.
I eat AF beta food all the time. So with that in your tongue, you've created some afferent information. Turn all the way this way. Do we break anything?
I think it's better.
No. Can you see more of my shoulder than before?
Yeah.
More of my shoulder?
Yes.
Go all the way this way.
Oh.
Can you see more of my shoulder?
I can, yeah.
Cool, right? Now, in someone's life, might they find therapeutic value in eating more beets or carrots and things like that, right? Are you going to do that?
Absolutely.
Yes, and if not, I'll give it to you in a pill. Or we'll do both, right? So now we've created therapeutic change, and I've helped the musculoskeletal complex through the nutritional means. We were talking about that a little bit earlier, like how do we do this if we're chiropractors and we're focusing so much on the musculoskeletal side thinking, but still using nutrition. So my notes reflect the idea that when I find neuromusculoskeletal issues, I can still support that through nutritional approaches. And so that's a cool demo there, right? Now, full disclosure. We talked about gallbladder pain possibly referring to neck, shoulder issues. AF beta food is something I often use for blood sugar issues or gallbladder things. Was I really super brilliant, or did I just think about anatomy for a second whenever she said I can't turn to the right as to why I grabbed AF beta food? Does that make sense? Now, do you have a raging gallbladder issue? Who knows? Maybe you do, maybe you don't. Did it hurt when they jabbed on you?
No.
No. So cool. So it doesn't hurt, but could range of motion still reflect a viscerosomatic experience? Yes, it could. So that's why we picked AF beta food first over the other things, because she couldn't turn to her right side. So it's not really that we're smart, we just no connections, right? The body knows what to do, we're just allowing it to tell us how to fix things. Cool? Any questions related on what we've demoed and practiced on so far? The concept of afferent stimulation manifesting as efferent change in the body was demonstrated, was tested, was experimented on. Some of you found things that hurt, some of you found things that got better by putting stuff in your mouth. Did any of you find something that hurt that did not get better by putting something on your tongue? You had one?
Kinda, yeah.
Kinda.
My spleen was, I mean, it got a little, but it's still kind of.
And it was on your tongue, or were we all doing the other weird stuff that we haven't talked about yet?
We were
I
doing-
tried something on my tongue.
We were doing the
but
weird stuff because I didn't know if you wanted me to open on all those.
Yeah, we didn't want to
bottles.
open those. No.
I didn't think so.
Okay, so we're going to build on that in a second. We're not going to tell you the answer yet. But potentially all that tells us so far is when she was jabbed on under her left rib cage and there was pain or discomfort, we tried something and did not get the expected result we wanted. So it just means we didn't try the correct thing. Or if we go back to our foundational slide concept of like, you know, what could go wrong? Well, maybe it's not a nutritional thing. Maybe it's a lymphatic thing, or a vascular thing, or an acupuncture thing, or an SOT thing, or a structural thing, or emotional thing. There could be something else doing it. It doesn't have to be a pill in tongue fixes everything. Pill for every ill works great for the pocketbook, not great for the patient. But I like to support nutritional stuff when we can, right? So it's possible that this referred issue is something else, and we just haven't got that far in the system yet. So the big question is why, right? If you're bored and you like looking at neurology things, here's a proposed explanation for why the hypothalamus talks to all the things, and anterior motor horns, and somatic nerves, and muscles change, and whatever, right? Boring. We just saw it. Put it on your tongue, something changed. We create neurologic afferent intervention. This is all of them. We already did the workshop here. This is a one-page cheat sheet. I probably should have showed you all this slide so you weren't going through each one. But you now know where the parts are. You can play with it. So now, we talked about these. Are these the only pills you might use for these particular spots? I hope the answer is no. Because hopefully you're thinking clinically and saying like, well, I use GastroDigest whenever people have digestive things. Why would I go to AF beta? Well, I go to AF beta food because I like AF beta food. But GastroDigest is on my shelf too. I might use that. I might use Elysium. I might use Malia. I might use some other thing. But I default to certain things in certain areas. And and I use a lot of standard process things, so that's why I put their stuff on here first. Plus, they hooked us up and gave us a bunch of things today for free. So.
This is your chart specifically?
Yeah, I made
It's
this
not
chart up just
from
for real.
standard process?
No, I just made this chart up for another class that a friend of mine did. So he and I taught a class maybe 6-8 months ago or something like that, and this is the chart we passed out that day, and it was easier to copy it and paste it again than recreate the wheel and throw a bunch of other stuff on there. But no, standard process has very little influence on what I say or do in my life, but they make good products, so I use them a lot. And I like their whole food-based concept. Remember, I keep picking on AF Beta Food, not because it's a bad product, but because literally the ingredients are organic beet blend, which has Swiss chard, juice powder in it, organic beetroot, organic beet leaf, juice powder, organic beets again, organic carrots, organic sweet potato, organic oat flour, organic calcium lactate, rice bran, magnesium, bovine liver, bovine prostate, nutritional yeast, bovine kidney, organic alfalfa. I think it's food. Like, that's why I use this on people. That's not to say that some of the other companies don't have place, but if I go grab a product from like Apex, it's chemical names I can't pronounce, but it gives me therapeutic value in certain situations. I like to start with food-based things when I can. Spanish black radish, the ingredient is 100% Spanish black radish. No, it's not. It's basically Spanish black radish with a little bit of honey and organic camwood holding it all together. So, how many of you eat Spanish black radish daily in your life? You do?
Well, I take that.
Good for you. Yeah. Or Spanish black radish is huge for like lymphatic related stuff. So when people have lymph congestion and they're sluggish in their bowels or sluggish in their immune system, things, you just need lymph to move, Spanish black radish will do that. But none of us eat radish or Spanish black radish in like normal life because it tastes disgusting, right? Like, how many of you eat liver every day? None of us, because it's disgusting. So we get it in pill form when we need to. Cruciferous Complete, I think this one, it's first on the list with the ovary stuff because I use this all the time for hormonal women. I don't know what percentage of my office is women, but every one of them is a woman that comes into my office, they have hormone issues. And I sell so much Cruciferous Complete because the sulfation pathway of the liver opens up and detoxes estrogenic activity from the liver and from the body. And everybody pretty much from the age of 14 to 45 who walks around with breast tenderness and pelvic pain and acne and PCOS and infertility and whatever has an estrogen to progesterone ratio imbalance, and they're estrogen dominant. Cruciferous vegetables like broccoli, cauliflower, things like that, grab onto those estrogens and drag them through phase 1, phase 2 liver detoxification and lower estrogenic loads in the body. But I can't have people eat a bushel of Brussels sprouts every day because they will smell every time they walk past anybody and they're just unwilling to do it. So I give them a bushel of Brussels sprouts per serving pretty much every time I give them this. That's not an exact number, I just made that up. But it's a lot of Brussels sprouts relative to the amount in the pill, right? So things like that, I use these products for that reason. I like standard process a lot for that purpose. It's a whole food-based way of throwing things into their life. So, we're getting into craziness now. No, it's not really craziness. It's we're now going to start muscle testing. Because now this is like, how do we take this concept of afferent information giving us efferent data? Sensory input, telling me about the body. This is a different paper. It's really small down here, but it's the mechanisms of manual muscle testing as proposed by the ventral horn theory by a guy named Michael Allen. He's a diplomate in applied kinesiology as well as a diplomate from the Hayden Institute, like neurology stuff. And his proposal for why muscle testing is what it is very neurologically centered. And the concept that he's going to talk here is diagnostic muscle testing. So that's the concept of the muscle testing standard as proposed by the International College of Applied Kinesiology. Diagnostic muscle testing is mainly an assessment tool for functional disorders. The human brain is receptor dependent. The entirety of the human neurological environment extends from the primary receptors and goes out, and all that information comes back up and tells the brain what's going on. So if I can tap into that system that goes both ways, I can get a huge amount of functional assessment into the body. And that enters in with manual muscle testing. So diagnostic muscle testing. The concepts we're going to start off with before lunch have certain concepts that are neurologically sound and clinically relevant, but it only tells us something is going on. Kind of like when we jabbed on Jeremy's ribs and he's like 3 out of 10. It didn't tell us gallbladder issues. It didn't tell us rib misalignment. It didn't tell us pec sternal dysfunction. It just said something hurts when I jab here. we expounded on that and said, what if I give you support through AF beta food or Diaplex? Does it help? And if it did, it gave us some data, but it doesn't tell us what we're doing. The same thing applies with muscle testing. It's just an insight of what's going on in the body, and now we look for change. Is there a structural thing I need to do? Is there a nutritional thing I need to do? Is there acupuncture thing I need to do? Whatever it might be, right? So hopefully we're using our diagnostic muscle testing ideas in conjunction with our clinical brain and data on the patient. We've got lab tests, we've got medical history, we've done physical exam, we've done orthopedic findings, we've done range of motion, we're now into muscle testing, we've done palpation, we've done all this stuff, right? We're using it as a tool that's bringing things around. So keep in mind, it's a snapshot in time. It doesn't tell the future of what's going on with this person. It doesn't actually tell us what you should do, but it can be an input through after information. Make sense? So, how do we do this? That's boring, we'll skip that slide. Too much writing. So, the most notable change from the past of how we considered what manual muscle testing was. How many of you, you're in Tri 8, Tri 2, nurse,
Trade.
Tri 8,
Try 9.
Tri 9, office manager, daughter, friends. Any of you have clinical teaching through like medical evaluation? Or not yet? Not yet, okay, perfect. In some mid-level tri, you had a physical exam class. They taught manual muscle testing and grading. 1 out of 5, 2 out of 5, 3 out of 5, 4 out of 5, 5 out of 5. Standard manual muscle testing as taught in conventional medicine is, can contractile strength support the load I'm giving it? Can I borrow somebody? Anybody, just first person to come sit right here gets to do the job.
Marcus,
Thanks, Ashley. Good. All right, so have a seat here for me. So let's pretend she was in a car wreck. She's being evaluated by the physical therapist. She's being evaluated by the medical doctor that's overseeing her care, and they think she has whiplash and possibly has a disc-related injury. They're going to do some level of myotome evaluation. They're going to look at major nerves as they connect to major muscles, and they're going to try and grade them on a scale of 0 out of 5 to 5 out of 5. 0 out of 5 would be complete paralysis and able to move. 1 out of 5 would be like muscles twitch some, but you can't actually move the joint against gravity. 2 out of 5 is something a little bit more than that. 3 out of 5 is like I can move it, but only if gravity is taken away. 4 out of 5 is I can move it, but if you give me resistance, it goes down. 5 out of 5 is I can do full range of motion, full resistance, full gravity. And it's kind of weird, but that's just the way things are graded. So let's pretend, hypothetically, that I wanted to test this deltoid muscle. They would tell me that I should stabilize the body, I should not cross a second joint, and I should apply some level of pressure in the range, relax, in the range of motion that she's going in. So since her arm does this, I'm doing like a scooping down motion, and I'm going to give her pressure. Hold really strong, and I'm going to count 2, 3, 4. That's a 5 out of 5 muscle test according to standard, traditional, conventional evaluation. And that tells us contractile force of the muscle is not paralyzed. That nerve is able to talk to that muscle. We're going to try it again. Ready, go. 2, 3. Good. That's perfect. If I did that type of an exam while attempting to do what I'm about to do in a second, we will both be so tired and sore tomorrow to be unrealistic. Because applied kinesiology, manual muscle testing, is no longer trying to determine contractile strength of it, but it's more of a neurologic assessment to the body. And we're looking for something called a lock or a stabilizing effect. So same muscle, same concept, but all I'm going to have you do is just don't let me move it down. And I'm just matching her resistance and giving just a touch more. Please don't jump on people and try and test contractile strength, because we're not testing that. We're testing for functional connection. Relax for me. So we come over here. She's holding it. Match my resistance. Good. And I just create a touch more. Let's pretend I want to do that to her finger flexors. Gently squeeze here. Hold. I'm just matching her resistance here, right? If I'm trying to test for diagnostic contractile strength, I'd be in front of her. She'd be in a perfect position. She would hold, and I'd squeeze as hard as I could, and I'd just crank on it. Try that again? You didn't work there. Hold. Okay, there you go. It really worked. Never mind. All right, so I thought it was broken for a second. So there's just two different ways of using a similar looking tool. And it's often conflated by individuals that look at what people that do applied kinesiology versus looking at like medical impairment ratings or things like that. And they're using something that looks similar, but they're talking about two different concepts. The concept we're about to discuss is contractile strength, no. Functional assessment of nervous system, yes. Okay? You crushed it. Thank you very much. And there are a lot of muscles in the body. How many muscles? Students that might have to do boards. I don't know. I was gonna guess 206, but I don't remember.
That's the
That's
ball.
a bone.
Bones, oh, that's bones. I don't know.
600?
There's like, there's like a
600?
million muscles.
I think
Who
it's
cares? There's a
600.
million of them.
These are you're an anatomy, so you know.
Yeah, I don't know. I graduated school in March of
That's
08,
the
so
first
I've
lecture
thought
I
a
wrote
bunch.
for.
I've lost a bunch of stuff in my brain since then. So lots of muscles, and then lots of variants of how to test those muscles, depending on which angle you're looking for and how things are going. I attempted to take this much information and slide it down to usable information for tomorrow. What's the most common presentation to, what's the number one complaint musculoskeletally speaking in the United States?
Lower back.
Lower
Lower
back.
back pain. So we'll start there. Because you'll probably see someone at some point in your life, or experience at some point in your life, low back pain. So I picked 10-ish or so muscles that will correlate strongly with low back related things, many of which will have strong overlap with digestive related things. And since we did a bunch of digestive related stuff with poking, we are attempting to merge a bunch of things together. Okay? So for example, we've got these muscles now. We just demonstrated that Ashley had great contractile strength. But there's a term we're going to reintroduce now, reintroduce for some people, introduce for the first time, which is normotonic, another term called hypertonic, and another term called hypotonic. I need another guinea pig, please. Someone who hasn't been up yet. Kyrie, come on up. This is my daughter, 14. What's your favorite supplement that you get to eat? Tell them, not me.
AF beta.
AF beta food. We got another AF beta fooder. Perfect. So this is Kyrie. She went to a rock concert last night and is moderately tired because she hasn't learned how to rock out like her dad yet. So let's pretend we're doing neurologic evaluations of reflexes. We're going to use our deep tendon reflex here. If I hit her patellar tendon, and she kicks, was that normal reflexive, hyperreflexive, or hyporeflexive?
Non-normal.
Looked normal. It looked like everything I've ever seen on Grey's Anatomy, right? I hit it, she kicks, she's normal. Let's pretend now that I hit her and she kicked for 5 minutes. Would we think that is too much, too little, or normal? Too much. We might term that hyperreflexive. Would be the reflex term. Hypertonic might be the muscle testing version. Or let's pretend I hit her and nothing happens at all. She is now hyper, normal, or hypo. Hypo. We can all see that in our minds, right? That concept. Lay on your back. Head this way, please. So, let's pretend now I'm going to test her quadriceps muscle. And this is the muscle we're going to focus on at the beginning. The quadriceps muscle attaches up here at the ASIS, anterior superior iliac spine, front of the pelvis. It comes down as 4 distinct muscles that merge again at the kneecap, and then the kneecap comes and attaches through the patellar tendon to the tibial tuberosity on the tibia, where that goes, right? The little bump we feel on our shin. This muscle, if we're going to contract it, lift your leg up, see how it does that? So when she activates this muscle and pulls, it squeezes and lifts her up. If she bends her knee, it squeezes and pulls her up still. So we're just going to take the normal movement of the muscle and attempt to see how strong it is. Keep it in mind that there might be normotonic activity of the muscle, hypertonic, or some level of dysfunction there, or hypotonic, some level of dysfunction there. We're not grading 0, 1, 2, 3, 4, 5. It's a different concept here. So what I'm going to ask her to do is remove other afferent stimulants from her body, just in case something there is jacking something up. Hold your leg there. She can hold, she's not paralyzed. I'm going to not cross 2 joints, so I'm not going to touch here. I'm just going to grab over here somewhere, and I'm going to stabilize at a convenient place on her body that's not on the muscle. I'm going to pick this spot. Press up to the sky. Good. I match her muscle and give a little bit more. Karen, keep your legs straight. Press up. Does that look too difficult? Doesn't look crazy yet. Easy stuff. Push up. Now, was this muscle hypotonic? Did it go weak when I pushed on it?
No.
Did not appear to. It appeared that she can withstand my resistance. Does that make it normotonic or hypertonic then? How do we know? What if it's over-facilitated or working too hard in the process?
Should you check the opposite? No.
Maybe. But here's how we'll check it. You might be able to check an opposite muscle because maybe there's a hyperfacilitation systemically. So you had just everything squeezing too tight. But you can see 3 gradients that we're looking at so far. We know it's not hypotonic because it's strong. We don't know quite if it's normo or hyper, but we're guessing normo because she was able to move it and hold strong. But this thing we're going to look at right now is probably the most important concept for baseline professional diagnostic muscle testing ideas. We've got a muscle here. Push up. It's strong. I can check for autogenic inhibition and figure out if this muscle is telling me the truth by providing an afferent stimulus. So we're going to use her leg. It's not an arm wrestle. You know, she's just holding it. I'm not trying to see if she can leg press me, and I'm not trying to hurt anybody, right? So we're just seeing how things are going. We're trying to find our lock, which we just did. We're now going to see if we can provoke the body through an afferent system in order to temporarily change that muscle to go weak. And if we can do that, then we'll now know how to differentiate between normotonic and hypertonic. Let's pretend I don't do this step. And I test this muscle. And it feels strong. I say, great, everything's great. And I let her go on her way. But she really has a hypertonic expression. That muscle test was a lie. Because it did not give me the correct information because it was firing inefficiently and inappropriately. Because muscle testing is not a genie in a bottle that tells me everything about someone. I have to use my clinical judgment to know what's going on in her world. So maybe I do a history, maybe I do something, whatever, and now I go test this muscle, and maybe she's got something neurologically misfiring in her body that doesn't allow me to find the data that I need, and she's in a hypertonic state, and now I'm using my tool, but it's not giving me data. Then we're both in a pickle. She doesn't get better. She writes bad reviews on Facebook. I don't get patients. She doesn't get to eat because I can't feed her. Right? It's just a vicious cycle. So I can use the muscle spindle cell reflex, kind of like how we just used a deep tendon reflex a second ago, to challenge the body afferently to see if it'll make a shift. So your muscle spindle cells regulate tone of the muscle belly. Your Golgi tendon organs regulate stretch of the muscle. We're going to focus on these. So leg straight, press up. She's good and strong. I'm going to take my fingers and apply some pressure and push up and create temporary weakness. Did I paralyze her? No. Just like whenever it hurts when you poke on someone, you put something on their mouth and it makes something change, we gave a neurologic stimulus of muscle spindle cell approximation. Her body perceived that afferently as muscles are in spasm and things are jacked up. Disable the system, quick, hurry, relax. They're going into spasm. And she said temporarily weakening of a muscle. That now tells me, the clinician, this body part is giving me good information. I can now use it as a clinical reference tool. Right? Didn't tell me she has a gut problem. Didn't tell me she has a knee problem. Didn't tell me anything yet. It just told me I can use this and get feedback from it appropriately. Cool? Autogenic inhibition, like involuntary nervous system to turn off something. Stimulated through muscle spindle cells, and if working properly, it should weaken the normotonic muscle. Hypothetically speaking, I take her muscle. She push up, she tests. It's strong. I autogenically inhibit. Hypothetically, I come back and I retest her, and she's still strong. What does that tell me?
Maybe
Hypertonic.
Hypertonic, not working properly. But what do I do with that information?
Find a different muscle.
You can find a different muscle and go look at something else, right? Or we have to go back to what we did before and say, maybe I can touch something, maybe I can taste something, maybe I can do something to get that muscle to come back to normal. Everybody flip to your last page on that little handout thing that I gave you a second ago. On that last page, you will see certain muscles that we're looking at. you'll see certain nutritional things that might support it, and you'll see certain organs or glands that might be tied to it. Please don't go home and think this was written on the 10 Commandments right next to everything else in stone. But these are concepts where neurologically there seems to be some strong association. So hypothetically speaking, if we had a hypertonic muscle or a hypotonic muscle, something that wasn't working properly with the rectus muscles or the quadriceps muscles, I might think, maybe a digestive related thing with the bowels. And then I look to my chart and say, well, maybe I could give her something like AF beta food, because that's what everybody's been using and working better, right? Because that helps gallbladder and carbohydrates, and maybe that can help small intestines a little bit too. Maybe I'm thinking probiotics. Maybe I'm thinking whatever I think, right? Whatever it is, it potentially gives me a way or a tool to try and normalize something for her that's not working well. Because if she comes in and she's got gut problems and hip pain and knee pain, and her quadriceps muscles aren't firing correctly, then I might clinically need to do something for her. Yes, I'll crack the snot out of her lower back. Yes, I'll change her diet and get her off of inflammatory foods. Yes, I'll give her some supplements to support that process. But I'm going to make sure those muscles are firing correctly when she leaves so that her body has a greater chance of maintaining the correction I'm doing with her. Does that make sense? So it doesn't tell us what, it only tells us normo, hyper, hypo. And we, as clinically relevant people, can figure that information out. Make sense so far? All right. If a muscle is tested, we're using the quad in this scenario for our workshop. It should be strong. But playing and finding a strong muscle is a weird concept if you've never muscle tested someone before. Because some of you are going to walk in and say, hold strong? Yeah, it didn't work. And then some of you are going to come in and say, hold strong? Push really strong like you mean it. Oh yeah, she's so strong. Push like you mean it. Oh, she's so strong, right? Yeah, I can't find a weakness. Or he's so strong. Like, how are we going to muscle test him? He's bigger and stronger and younger than all of us in the room. He ran 12 miles this morning at 3:30 in the morning. Like, come on. How could we ever find a weak muscle on that guy? But it happens because we're neurologic functional medicine assessing, not contractile strength, seeing who can bench press more stress testing. Does that make sense? So, we find a strong muscle. We determine is it normotonic or not. Hypertonic will not go weak if you muscle spindle cell down the activity, and hypotonic will just be weak by itself. And weak by itself may mean the person's jacked up, and it may mean I don't know what I'm doing yet, and it may mean a bunch of things. So we just get started with that. Cool? Let's figure it out. All right, break up into your groups and go find and see if you can find a muscle that works. We're using let's just stick with the rectus femoris for right now. If you find a muscle that's strong, test and figure out if it's normotonic or not. If it's hypertonic or hypotonic, play around and see if you can get it to go back to being strong again. 10 minutes or less. Ready, break.
Can I go get?
Is that fun? Yes. Okay, the hardest thing, just to keep in mind, is some of you have never tested a muscle prior to today. Please don't compare your muscle testing capacity to someone else who's done it in school or for 15 years of their life, or that started going to chiropractors that did muscle testing when they were 12 years old and seen it for 30 years of their life. Like, it's a very different experience, right? But it's practice. Maybe you play an instrument? Ever? Piano, guitar, sing, anything like that? Mm-hmm. On day one, were you as good as you are right now? Never, right? Sports, same thing. Medical professions, same thing. It just takes time. Have some grace with yourself. Play with it. Don't get too bogged down on am I doing it right or wrong yet, but just the concept of getting the feel, right? How many of you found a muscle that was normotonic? Raise your hand. Any of you find a muscle that was hypotonic, weak to begin with? Yeah, that's exciting. Hypertonic? You had one, or
I
you
didn't.
found one?
We found, yeah.
Hypertonic.
It was my right.
Seems crazy. All of us have ridden together on the car ride. Maybe it's something up in Austin.
Brian College Station.
Bryan College Station. Somewhere not around here, right? Once you leave Houston, it just gets sketchy. So, this is my other daughter, Cambria.
Yes.
She is joining us, it looks like. I'm sorry, remind me your name again? Raylene. Come on over here, Miss Raylene. We found something neat on her a second ago, and which was a hypertonic muscle. And so we were just experimenting and brainstorming out loud on how we might do things. So just to begin with, we're going to attempt to make appropriate positioning a thing. I rarely have people touch themselves because afferent information is sensory input to the body, and I don't want what they're doing to accidentally stimulate something else. I rarely have people like chew gum while they're being tested because maybe their jaw is doing something that their brain is thinking is a stimulant, right? Some people will have people take off of watches or take off belts or other things because what if my cell phone is causing my whatever to misfire? And I try to test people in the environment they're in, so I let them keep watches on or things like that. Sometimes I'll have them take cell phones out, sometimes I won't, but just something to keep in mind that there are things that could influence what's going on in her life that could make things happen. So that's why we're attempting to be as neurologically sound as possible as we're testing. So we've got this leg muscle, push up. And the reason I demonstrated this, because we saw another group sit on the edge of the table and do the leg kicking out as if you were doing this level of rectus femoris test. And that's a fine test, it has its place and things. We attempted to do this one just for the sake of this class. We talked about there being 1 million muscles in the body, not an actual fact, but a lot of muscles. And all of those muscles having certain nerve and associations and things that go along with them. Test however you want to today. But for demo purposes, I'm just going to show this process. Leg straight, press up to the sky. We've got a good strong muscle. I attempt to activate that muscle to see if it's normotonic, and it's not. So we have hypertonicity. What does that tell us?
Something's going on.
Overstimulated.
Something's going on and the nervous system is overstimulated somehow. How would we change that?
You could change it a lot of ways.
Sure, give me one.
You could put something in her mouth.
Put something in her mouth. With y'all's playing around, did y'all put something in her mouth?
No, because we left her broken for you.
Left her broken. So, if you were using your quick little cheat sheet and you found rectus femoris has some level of imbalance and you wanted to attempt by putting something in her mouth to make a change, what might you do?
Small intestine.
Something small intestinal related?
Xanax.
Zymex 2 is on our shelf here, so let's experiment by giving her something like Zymex 2. Put that in your mouth for me. No, I'm sorry. You don't have to be like kosher, halal, anything like that.
Oh no.
Okay, perfect. Throw that in your mouth for me. We've created an afferent potential change. She now has taste. Her taste buds are sending signals to her brain. Her brain is saying, let's let magic happen, possibly. Or, hey, I don't need this, possibly, right? Press up for me. Good and strong. Press up for me. Cool, right? Normotonicity was reestablished through afferent taste response, allowing good information to be presented. Could she benefit from having that in her life? Maybe. We don't know yet. But it at least tells us something, right? Besides putting something in her mouth, is there anything else we might do to try and make this happen? But wait, let's see for a second. It's not actively engaged. She might have some residual taste in there, but let's just see what happens. Push up. Good. Push up like you mean it. There we go. And now press up. Yeah, so she's still got enough something going on to where she's testing appropriately.
Yeah, I can still taste.
Get it.
Yeah,
So-
that one's yummy.
Jump off. Let's borrow you for a second. You said yours was moderately wacky also.
Yes.
We're going to try something. Line back for me. This leg straight. Press up. Good and strong. Press up. No, I get a good okay test there. Push up. Good. Press up. No. You seem okay to me. In
Yeah.
that version of the test at least.
We put a thing in my mouth
Oh,
and
okay.
tried again.
Okay.
We were in there.
So you did some things to make it better. Anybody else have hypertonic anything? In a second, I'll come back and do more with that because we'll give it time to process out and not be a neurologic stimulant anymore. But that's something we could do. Let's pretend I was a chiropractor
I was gonna say
and I had a quadriceps muscle weakness. What neurologic aspect of the body would I look at that might tell that what to do?
a low back.
Something like that. I'm sorry?
2 through 4.
2, 3, 4, right? L2, 3, 4 talks to the quadriceps muscle. Maybe, kind of like how we poked on her neck and had her turn earlier and we saw a change. Maybe I would push through the belly or have her push on her back or something and retest that to see if I can create a therapeutic change through afferent stimulus of a bony prominence. Make sense? Those are 2 easy ways that we've covered so far of potentially restoring neurologic tone to an area so that we have adequate and appropriate information coming back in. So, here's a bunch of muscles. In your slides, there are old ghetto versions of pictures that I took directly from the ICAK textbook, which if you haven't noticed, there's a bunch of books on that counter over there. Those are just some of my muscle testing based technique books if you want to look through them. There's, the ICAK textbook is over there. There's a couple of seminar notes from different classes. And there's like 6 or 7 different books there. But I took all of these particular pictures away, or out of the big blue book that's over there, so you have a chance to at least see what it might look like to test. I couldn't find the way I really test the glute medius, so I just use this picture anyways. But I'm just going to demonstrate some of these for you, so you have a chance to see it. And to be fair, it might be a little bit cumbersome if you aren't familiar with where these muscles are, what their actions are. But I technically try to make it easy for you. With the idea being, every time a muscle is activated, it shortens the joint, right? So if I want to test my biceps, and I don't really know where I'm supposed to go, if I just say, biceps, do your job, and he goes, oh, okay. If I put pressure here and stabilize somewhere else, I'm now going to test the biceps, right? If I'm going to test my triceps, what does the triceps do? The gym says this is how I work them out. Okay, so I will push down. Is that going to make sense? That concept is the basis behind muscle testing. And so when we look at the glute medius, since it sits right about here in the body, it's a mover of the leg going in that direction. Fancy word is abductor, is a common thing for it. Glute maximus lifts the butt up, your gi out, like the girls say. I just said that for them because I knew that. You know that word though. You're not gonna have to recognize that word. Good. All those old people in the room are like, "What are you talking about?" That's what the teenagers say nowadays.
Those two.
So glute max. Tensor fasciae lata is this one right at the top of the IT band. So it internally rotates the leg and pushes up and out. I'm going to show you all these muscles in a second. The rectus femoris, this was just a ghetto test, and I didn't like how it looked, so I wanted to say, don't do it this way, because this is how they teach you in school to do it. Where the 2 hands like right above the knee or whatever. It's just a crappy test, because the quad's so strong, and we're not looking for contractile strength. But a lot of times we think about like, oh, I'm going to test this muscle in the way they reminded me at school, and different application of what we're doing here. Piriformis is going to be, leg is in a position that rotates. I'm going to demonstrate these in a second, but just so you have a chance to kind of picture what you're doing, you're testing a butt muscle here. The psoas, the iliopsoas muscle, is going to externally rotate the leg, abduct it a little bit, and flex. So it does a combination of things. Quadratus lumborum, these are these muscles right here in the back that are big stabilizers for the low back. The rectus abdominis here, the curl ones that look good on the beach. The hamstrings back here, they're going to bend your knee and help with glute max extension. And that's all of them, right? And that's a lot, especially if you have not been through past basic A&P in your life and you have seen those in real life being activated. So we're going to demonstrate them slowly at the beginning. Then we'll break up into groups and mess it up a bunch, and we'll keep just learning. Because that's what we do, right? We're just here to learn. So I need a person, Cambria, since you're standing, will you come be my guinea pig? Your head here, your feet here, on your back. Alright, so I'm just going to start from the beginning. And the reason I would I picked these muscles in the way that I did, relax for me, is that I can do most of them from her being on her back. Remember we talked about the adductor, the glute medius muscle is an abductor. And that picture showed him laying the person on the side and testing behind. That's a version of doing that. But I'm going to start with the glute medius by having her remove afferent information. You're not chewing gum or anything?
No, but I had a mint in my mouth.
That's afferent information.
It just went away though, like it literally just
Alright.
dissolved like 2 days
Just
ago.
hope it doesn't jack anything up. So, we're in this position. We already learned rectus femoris, so we'll just go to that one first. Legs straight, press up to the sky, push up. So we're good and strong. This leg straight, push up to the sky. Good. Are those hypo, hyper, or normal?
We don't
know.
Normal or hyper?
Normal or hyper? We don't know though, right? So I can challenge and test her again. Push up. We now suspect Normal tonic muscle. That's going to give me good data. Push up here for me. Good. Relax. And push up. Oh, snap. Let's try this again. Now press up. All right. We got a broken leg. Okay?
Amputate.
Something's messed up here. We don't know what yet, but something's messed up. But we're in evaluation mode. I'm not going to stick on that yet. I'm going to the next one. Let's now go to glute medius. Glute medius is going to adduct, wait one second, abduct the muscles. So I don't want her to recruit other things. So attempt to recruit as best you can in whatever way you think that means. Push out. Okay, she starts bending her leg. She's doing something to try and protect her from going weak or moving. So I gotta just stop and say, this is what I want you to do. We're focusing on this leg here. Keep your leg straight. Keep your leg straight. Push your leg to the outside. Now push like you mean it.
I know.
Isn't that crazy? So her adaptation to weakness was to try and recruit other muscles to not be weak, because nobody likes being weak. It makes them feel bad. But they're here in the doctor's office to get better, but they don't want to be weak in front of us. It's okay. Guys are the worst, but when she just barely bent her knee like that and she curled up over on that side, push out. Now it's strong. And so I need to be aware of potential adaptation for the individual who's going to try and lie to me. Unintentionally so, but trying to not be weak, because they're trying to everyone wants to get an A+ on their test. And I'm doing a muscle test now. Keep your leg straight, push your leg to the outside. Nada. Hyper, hypo, normo. Hypo. That's weird. Hyper, normo, hypo. Leg straight, push your leg to the outside. How do you walk? I'm just joking. So we got glute medius weaknesses, right? We're skipping glute max for a second because that would require to flip over, and I just don't want to waste the time on doing that right now. Tensor fasciae lata. It's this one right here. Okay? Leg straight, turned in. You're going to take your leg and push up and out to the outside corner of the room. And that does okay. This leg straight, turn in, push up and out to the outside corner. Not working. Do this one more time. Push up and out. That one does okay. Hypo. Rectus femoris we already did. Piriformis, we showed it face down. I'm just going to show you a face up version so you don't have to have people flip over. Bend your knee. Her knee has been put into this position. She rotates in just a little bit. Hold your leg there. Don't let me pull your leg out. And I'm just going to rotate her leg. Push. No. Just out of curiosity, based off of her muscles that are weak, do you start coming up with ideas of what you think might be going on with her? Any thoughts so far? Just looking at the chart of which muscles are weak, which organs and glands might be associated with it, and which nerves might be going on with it. Do you start thinking clinically about this individual who has hypertonic quad, hypotonic glutes, hypotonic piriformises on both sides? What do you think? I'm sorry?
I asked if she's on her cycle. Or
Are you on your cycle? No, not on her cycle, but you're thinking
Just finished.
something hormone related, possibly ovary, estrogen, progesterone, something in that world, hormones. Anybody else have a different thought?
Digestive.
Maybe some digestive thing, because we had this quad that was a little bit weird, right? And that TFL that was a little bit weird, so maybe we're like, oh, maybe her digestion's a little bit off. Maybe her ovaries or reproductive system is a little bit off. We don't know yet, because we didn't take a history, we didn't do questionnaires, we didn't do an exam. We're just trying to take data points to see the picture of this patient who wants to get better, right? So as an iliacus, we're going to just test a version. We bring your leg up a little bit, externally rotate and pull it out a smidge. Keep your legs straight. You're going to push straight up to the sky. That did okay. Please don't try and test this muscle from this position. It's too wonky and it sucks. Walk around the table. Legs straight, push up. Good, so those both appear to be okay. How might I do a autogenic inhibition for the psoas muscle that attaches to her spine, and she's got all of her bowels and her guts and everything in front of her, and I probably can't get down in there and autogenically inhibit it like I would with some of these other ones? It's a great question. We'll answer that after lunch. But as of right now, we have no way of determining if that's a hyper or a normotonic muscle. We just technically see that it's strong, but we don't have a way to figure that out because I can't get that muscle belly to challenge it like I could with some of the other ones yet. Continuing on, quadratus lumborum, grab the table with both hands. Both feet together, hold them right there.
I'm so
Push your legs that direction and hold strong. Try them, like you mean it. You're impressing people here.
bad
Let's
at
go.
this one.
That doesn't work, right?
Always bad at this.
Always bad at this one. This tells us
Me
more
too.
about your life
Me
or
too.
your dad. One of them. Push that way and hold. So quadratus lumborums are not working. Rectus abdominal muscles, sit up for me. Scoot to where your feet are. Okay, like that. There you go. Sit up straight and tall. Give yourself a big hug. What do their abs do? They flex. So we're going to do opposite of that. Hold strong. That's a good strong test. We're going to turn this way. And just like that for a second. Stay there. I'm going to push that way, testing oblique muscles. Good. We're going to come this way and hold. Good. Ab muscles appear to work out okay. Flip onto your belly for me. We're at hamstrings and glute max are the two we haven't looked at yet, which we do while facing down like this. Drop your head down, arms down. Try and keep your head straight. The other tables will be easier for keeping her head straight. This one not so much. Hamstrings, she's going to bend her leg. Hold it, wait, 1 second. Hold it just like that. Sometimes people will cramp. If you just put your hand on their hamstring while testing it, it breaks all rules you learned in school, but it technically prevents them from cramping. I don't do that until they start cramping. Now hold strong. Good and strong. Good. Relax. Now this one hold. Good and strong. What if I want to check autogenic inhibition? Does it go weak? It does. Now hold. It does. Glute test. Glute max. What muscle is this, Kyrie? The giat. Hold that right there and push up. Good and strong. And hold. Good and strong. Similarly, we can turn it off. Hold there. Nobody wants that to happen in their life though, not the girls. Hold that there. Oh, I'm sorry, I forgot to turn it off. And then it turns off. So that works like we need it to. Cool? I know that was fast, and that might be a little bit overwhelming at the beginning, but this is why we're here. Just play around with some stuff. Flip on your back for me. Let's pretend that Cambria was your partner, and you found certain muscles that were weak. Remember we saw tensor fascia lata over here was weak, hypotonic. We saw quadratus lumborum weak, glute medius weak, quad hypertonic, abs were fine, psoas was fine, hamstrings and glute were fine. Rectus, yeah, we already talked about those. So, is that more or less what we saw a second ago?
Yes.
So, what do? We can start playing with stuff. We saw earlier, we can put stuff in our mouth and see if those weaknesses become strong and if the hypertonic things become normotonic, right? So, let's just pretend because we had some things like ovary-related muscles that were weak. We saw the glute medius were weak on both sides. We saw the piriformis was wonky. Piriformis, yeah, both of them. All four of those muscles, because all four of those were reproductive organ related. I grabbed cruciferous complete because it's the first one on my list for reproductive related things. She puts it in her mouth, and we just check something and see. We remove afferent stimulation. Hold there. Oh, bend your knee. We're going to make it exactly the same. Hold there. Don't let me move it. Did not change it. Hold here. Don't let me move it. Did not change it. This is a crappy system. We should throw it all away and go home and be done. Push, because it didn't fix what we were looking for. No, just means that that thing that I tried isn't her particular thing right this moment. Go and spit that out.
It stuck to my tongue.
All right, let's try. Wait a minute, 1 second.
That's not how we learn muscles. I like a lot of this better than how we learned how to do the
I know. Are you talking about in
physical
PE?
exam.
Oh,
Yeah.
no.
So I just know a little bit more about her.
So you just missed that comment though.
So what?
You needed to hear that.
What happened?
He
Oh,
said
I was
that-
just saying.
He said that's not how we did that in.
Right, we did a lot of them differently, but I like how these stress the muscles more specifically.
Oh, right.
Yeah, yeah.
Differently as in like in school?
Yeah, yeah.
Yeah, school's garbage. I mean, they just teach a different way. They just teach
Yes.
a different way.
Yeah,
I went and grabbed some different things. She has a condition known as Hashimoto's autoimmune thyroiditis. And she also has celiac. So there are certain things I just can't give her. Put that in your mouth. And so all of these that say gluten-free, I can now use for her. And there are some that I want to use that don't say gluten-free. So we're experimenting with different versions. So that's chlorophyll complex. Hold there. Don't let me twist it. And wait a second. How many of you see chlorophyll complex on your reproductive organs and glands one?
Mm-hmm.
Is it on there?
Oh, no.
Chlorophyll complex?
No, it's under large intestine, small intestine.
Isn't that weird? Why would I pick that for her and then test? Push out for me. Glute medius got stronger. Push out. Piriformis got stronger. This leg straight. Push up. Good and strong there. Does it go back to normal atomic? Now push up.
Oh snap.
Ding. Grab the table with both hands. Both of your feet go that direction and hold. That one that we failed earlier. Push both of your legs this way. Hold.
Congratulations, you
Oh,
just earned
not that one. Hold again.
chlorophyll complex.
All right.
Chlorophyll
So basically, like everything but this one carotidus lumborum got better with chlorophyll complex. But it's not on your list. And the reason it's not on your list is because most people don't think chlorophyll complex for reproductive. Oh, you're gonna have stained green teeth. That's gonna be awesome in your braces. You're gonna have that stained for like a week. Probably.
Halloween is upcoming.
Yeah, it's gonna be crappy for you. Good luck.
Did she eat it?
Do you have a dance tonight?
So
No, I'm
chlorophyll
not doing
complex
it.
just
I
has a
know.
ton of like.
I know, but it is.
Cam, what color are your braces?
It's gonna stain
Oh,
your
so
teeth.
So nice,
It's
good.
you'll see.
Everything.
It's gonna be great.
So, so good job.
It's like a water.
You'll be fine.
It's oil based.
As long as you're not kissing someone with hair, it's fine.
I'm babysitting, so
Perfect, you'll be good.
I'm not kissing anybody.
Alright, so.
So that's because of the greens in it,
It's the chlorophyll.
maybe, possibly.
So chlorophyll,
I mean, for her physiological.
right.
Is it
So
gut
chlorophyll is a
and-
huge one for gut related stuff. When you think about mucosal barriers and like tight junctions and zonulin and leaky gut and leaky barriers and stuff, chlorophyll is a huge bang for your buck in that world. So that definitely comes up in like the intestinal related stuff. It's got a bunch of sesame seed in there, which helps with the immune system as well and builds up good stuff. The reason it is a hidden secret gem for women is that it balances progesterone in their life. And that is the craziest thing because you will never hear it by anybody. But I heard it from one guy that told me, he says, if you ever have someone who has weird hormonal cycles, especially if they bleed nonstop, if someone comes in and says, I bleed 21 days out of the month, give them chlorophyll complex and it'll help put progesterone and estrogen into a more appropriate place and just have them take it until they start bleeding their normal period again and then keep them on that dose for a while. So you might start 1-1-1 and then if that didn't work, the next day you go to 2-2-2 and then 3-3-3 and then 4-4-4 and one of those will stop their bleeding and then just stay at that dose for a bit. So it's not written in anything that standard process has.
I love that.
Nothing is there. But it's this cool thing that you'll just, since I see a bunch of hormonal women, I wow people with stuff like that sometimes. And so in her world, I didn't know your cycle just ended, but I know she's female. You know, she's lost cause there. I mean, imbalanced. I meant imbalanced. She's imbalanced as a female. No, that's I'm just joking. So as a female that has autoimmune thyroid stuff, that has autoimmune gut things, I just needed to pull something a little bit differently than what we had on our original stand here. And chlorophyll was the most likely one I wanted to try, so I did that first, and made most of the stuff get better. But we still have this quadratus not change though. But I saw one pill make a substantial change in everything else. So I'm leaning toward you probably need chlorophyll in your life. But I'd probably just adjust her back also. Like maybe it's really just a bone out of whack that's causing dysfunction elsewhere. And some of those muscles might have been compensatory. So if this was a normal office visit, I'd recheck on whatever she was taking before. I'd remind her about how important it is to be following the dietary recommendations we've already given her. And I'd remind her that sleep is important. And since you don't sleep anymore in your life because of cheer and football and all this stuff that she's involved in, we got to work on that. And by the way, you earned chlorophyll complex because of how your exam presented today, and we're gonna crack your back, pay Liz up front, we'll see you in 2 weeks. Right, something along those lines is what would have happened in that visit study. But I was able to use diagnostic muscle testing in relationship to the rest of the clinical picture to help me hone in on something that was uniquely specific to her, that's not in a textbook that says when someone has a weak quadriceps, give them chlorophyll complex. Does that make sense? We can use our clinical brain to support nutritionally while we're modifying lifestyle and diet, while we're doing our chiropractic things, or acupuncture things, or emotional things, or whatever else we're doing, we can tap into that world. Cool? Let's go practice with each other. Or do y'all need to see me run through all the muscles one more time?
One more time?
Do
One
it
more
fast,
time?
one more time.
One more time fast. New person. You're already broken.
Sorry.
One or the other.
You're fixed.
I need a new person though.
Congratulations.
Someone who wants to be poked on. You look like you were moving first.
Oh, did somebody else?
No,
No,
you're
you
doing
go.
it.
You're up.
Head here.
Sure, wherever you like. Is that gonna bother if you stand right there on the edge? Actually, let's have you spin around so I have more room to stand on the edge of the
Okay.
table.
Oh,
No, that way I'm not like in your face.
me spin, right? Just ready. Okay.
So, I'm gonna just quickly run through some tests and call them out as I'm going. And if you have a question or you need help to review or demo it again, let me know. So we're gonna start with glute medius first. So I like that she's not touching anything, she's not chewing anything, she's just being the most awesome person she can be. Push your leg to the outside. I'm looking for things to compensate. Is she bending her knee? Is she compensating somewhere like that? Those appear to be strong. This leg straight, press up to the sky, appear to be strong. So usually I'll just kind of screen periodically to make sure that it's doing what I need it to do if I'm just seeing how things are working. So I like the quad.
Push up.
Push up for me, yeah. I like the quad for that reason, because I can just quickly screen it. Whereas if I'm doing a glute, I gotta come way over here and grab the butt, and then I gotta come run back here, and it's just, if I don't have a specific rationale for needing to figure out if that muscle's working well, I may not screen every single one. Does that kind of make sense? So I'll just kind of test some things out. But so far, quads are, or rectus is doing good, glute medius is doing good. Let's do TFL, leg straight, push up and out that way. Good. This leg straight, push up and out that way. Good. We're gonna take this. Notice neither one of us are trying to out-muscle the other person. Push that way. Oh, that again. Okay, that works okay. And then this one here, push toward me. Good. Grab the table with both hands. Both your legs, push that direction and hold. Whoop, we got another winner. Quadratus lumborum on this side was a little bit sketchy. Push that way and hold. Good. Both quadratus lumborums. Could just be that her tailbone's out of whack. Maybe your SI joint needs to be adjusted. Maybe your back's out of whack. Maybe she's got Crohn's disease. Who knows? But we were just thinking out loud, like, why let quadratus lumborum? I'm sorry, what?
No, I said awesome.
Oh, so yeah, exactly. You know, so we don't know what's going on. We just know weakness, and so we need to use clinical tools to figure out how we might correct that, right? So QL, rectus, piriformis, TFL. Let's do. Sit up for me. Let's get to the edge again. Good. Give yourself a big hug. Arch your back just a touch, and just stay right there, and hold strong. Good. Turn this direction. Arch a little bit. There we go, and hold. Good. And this way, and hold. Good. That was a poorly done last test. I pulled instead of pushed, but it worked. Flip on your belly for me.
Arm side.
Sure, just like that's fine. Hold there. Bring your heel towards, oh no, just relax. Kind of bend your knee.
And
Bring that this way. Hold strong. Good. Relax. Hold strong. Like I said, because of ease of testing, this is a common one I'll use to see if it's autogenically inhibited, and it is. And push. And those do what I need them to. Push up to the sky. Hold your leg just like that. Okay, wait 1 second.
sorry.
No, you did good. Lift your leg straight up. Do you all notice her leg? What just happened there? So everybody just come look at what happened with her leg for a second. I don't know if this is a real thing or not, but it's something that just caught my attention. So everybody stand up and come look right here 1 second. I want you to bend your knee and lift your leg straight up.
Nope.
Does it go straight up?
No.
No, she kicks it off to the side and looks like she's recruiting over here. Now is she, I'm sorry, say that again?
That's where I have my pain.
Oh, right.
You remember the?
Oh, yeah.
It doesn't hurt now, but it might be compensating.
Right, potentially it's a learned adaptation due to chronic low back issues or whatever. But when I bend her knee and say lift up, and I watch her kind of flare everything to the side, it makes me nervous. It says maybe that's a test that's going to be strong, but it may not be as strong as I need it to be because she's just in the wrong place. So stay just like that,
Okay.
and now press up to the sky. Okay? When I put her into a straight up and down place, I got a weakness. Bend your knee and lift up. Keep it just like that. So she flared out and hold. And I don't have a weakness. But it was just something that as I pulled her up and look, you just noticed the shift of the adaptation. Kind of like when Cambria went to bring her leg out, she bent her knee and kind of cocked her hip. And I was like, oh, wait a second. I need to stabilize and say, wait. I need a better test. And I want you to give me good information. So from right here, hold it just like that and keep it there for me. And now hold. And it doesn't work. Which could be why she gets this thing over and over again, that we adjust and she comes back, and we adjust it or whatever. Lift up. There was less compensation there, hold. Good. Do that again, but maybe I just want to really, really force it. Keep it just like that. And now hold. Yeah. If I really pull her knee back in, but it didn't adapt as much as this one did. Is that going to make sense on how we might notice something like that and say, oh no, I'm back in school. Oh, strong test, you have no problem. But we're just missing it because we're not noticing the adaptation, or trying to look for contractile strength rather than functional neuro assessment. Cool? Try walking around for me, see how things are going. I mean, don't walk around. I say that after every time I tell people we got the table. Go do whatever you want to do. We're going to break into groups and do whatever you want to do. Does that make sense? Alright, thoughts or questions? So our concept for this next workshop is we're going to test the muscles. We're going to look for autogenic inhibition through some of those muscle spindle cell responses. And we're potentially going to use oral or touch to see if we can make change. So like on a glute max weakness, I might look on my chart and say, well, maybe one of these things are going to help. But what if I check some of them and they don't help? Well, then we just go off the reservation, do whatever you want. Put something else in, like chlorophyll or something, or just test it out. Make sense? Ready to break?
And I think we all were like, ooh.
I was like,
The
how
chlorophyll
many
from-
chlorophyll do I need?
How many chlorophyll do we need?
I love chlorophyll. Like, I think my
Chlorophyll's
body
great.
likes it.
These are somebody's notes. Would you like them back?
Oh, yes, please. Thank you.
Sure thing.
I will. Here's your pen.
Alright. Everybody had a chance to test those super easy to remember 10 muscles that we'll never forget after today, right?
Yeah.
Super easy. I know it's a little bit of a learning curve, no big deal. Like we said before, there's lots of muscles, and there's lots of variants to that. But we picked these 10 as a way to try and create a flow in order to just start somewhere. So now you've got a concept in mind, which is try to look for compensatory movement patterns or adaptations when you're testing someone for something. Look to see if you feel comfortable doing the thing you're doing, because if it feels awkward and weird, it's possible that you're not in a good position for it. Can I borrow you for 1 second?
Yep.
Just lay up here in whatever way you like, on your back though. So hypothetically speaking, if I'm testing his psoas muscle, and I'm way over here, and it just feels like I just don't know what I'm doing, or it feels awkward, or I'm pushing him off the table or whatever, maybe I'm not in the right place. Now, could I test it that way? Yeah, plausibly. Is it the most accurate of tests? Yeah, plausibly, right? So we might look for different ways in which we do it. So therefore, if it feels awkward, maybe if I just stand in a different place and do the same movement, I can be like, okay, that feels more stable to me. I don't feel like I'm going to hurt my back or lean over or fall on top of the patient when I'm doing something, like, you know what I'm saying? So maybe we're looking at it in that way. Maybe, let's have you grab the table and push your legs like this and don't let me move it. Maybe if I'm doing this, I'm thinking, that's weird. Why is he weak there? And I'll hold here, hold. And that's weird, that's weak. Hold right here, push up. Man, you suck. You're weak on everything, man. So maybe it's user error, but maybe he's really just broken, right? So we don't know yet. But maybe I was doing stuff maybe either too heavy-handedly or not stabilizing properly, so he had no anchor points to grab onto. So let's try this again and maybe give him a better stabilizing aspect. Hold strong. Push your feet that way to the left. No, I'm still not quite convinced that works. So I just modified my test a little bit, gave him a little bit more stability, and it still felt less than what I would think it should be. Hold there. Has anybody tested these on you?
Yeah, they did.
Hold there. Were any of these weak earlier?
Yeah.
Okay, so we're potentially finding good inter-doctor reliability, so that's exciting. That would have been awkward if I'm the only one finding weaknesses and y'all aren't, Legs straight. push up to the sky. Okay, see that one's not weak though. Whereas before when I grabbed way down here and pushed more aggressively, we made it go weak. So we just want to be mindful of what are you doing. So testing wise, it is a learned art and skill, just like playing the piano, riding your bike, performing brain surgery. They're all just things you practice over time and eventually get good at, right? Generally speaking, we strive to avoid creating pain during a test. So let's pretend he had knee surgery last week and I do this and he goes, ow, that hurts. Would I do it?
No.
Well, I don't know, I would. But I'd be cautious, right? I test people with knee surgery all the time. Literally, they come in and they've still got the pins in their stuff, or their tubes from their ports for like breast stuff or whatever, right? Like they just had reconstructive surgery last week and they're still wrapped up and their ports are in. I will still test them and do things, but I have to be mindful and cognizant of what's going on with that individual in the testing process. So maybe on this leg, I can take it and push up, and I can push at that level because it didn't have knee surgery last week. But this level, I might be a little bit more like, okay, hold it there. Can you hold it? He's like, oh, that hurts. And I just go, tss, and it just kind of falls over. I'm like, okay, I can get some data, and I can now try and make that knee that just had surgery last week do better. So I might have him jab on where the nerve comes out. I might have him put something on his tongue. I might have him stabilize the SI joint. I might shine a laser on his knee. I might have him whistle Dixie. Whatever it might be, for whatever reason I'm trying to make it better, I can now try and see if that knee surgery gets better with some type of afferent stimulus that I give him. Does that kind of make sense? Joking about whistling Dixie, but that would stimulate right brain activity. And maybe he has left brain over facilitation and right brain under activity. So now I can have him whistle or sing a song that stimulates a portion of his brain that now gets a change in his body. Or what if I ask him to count backwards from 1,000 by sevens? Because I wanted to stimulate left brain activity. And he's like, I don't even know how to do that. So now he's like, okay, 1,000, 993, and he starts the process, and now his muscles change as a result of that. When I've provoked a specific part of his brain, and I'm now looking for efferent change downstream as a result. It's weird. The muscle testing world just opens up a window of opportunity to evaluate the person. A second ago, we were playing with Liz in the other room, and we were given a hypothetical scenario. Let's pretend Liz comes in, and she says, I've got gut problems, and I've got back problems. And you went through and you tested these basic muscles. And you tested glute medius, and it was strong. And you tested tensor fasciae lata, and it was strong. And rectus femoris, it was strong. And psoas, it was strong. And piriformis, and it was strong. You're like, dang it. All these back muscles are testing like we think they should. And we went back and we tested, and they're all normotonic. We're like, that's weird. I'm stuck. I only know these 10 muscles, and they all appear to be working properly. How do I help this individual? And we were brainstorming about the idea of using a concept, which is provide a muscle test and look for a weakness, and we just extrapolated that out to a different movement pattern. What is it called if you bring this leg toward this leg and you activate this muscle?
Adduction.
Adduction, right? Have we learned a muscle that does adduction in isolation?
No.
We haven't. So therefore, we can put on our clinical brain and say, well, I know that abduction is this test. Abduction plus flexion is that test. Flexion is this test. Adduction and flexion was this test. Well, now we're missing one. What brings the leg that way? Who cares? What if I don't know the name of the muscle? But I know the function that I'm looking for. And I can just say, okay, leg straight. We did all these other things. So leg straight, bring this toward here and hold strong. And I just made up a test which is clinically relevant, even though I didn't know that the adductors and the gracilis muscle were supposed to do that. Does that kind of make sense? Mm-hmm. So now we did that on Liz, and she was strong. And we said, dang it. Well, maybe if we do some flexion and adduction, we can find something. Push that way. And on Liz, that went weak. And we said, oh, cool. Then how do we fix it? What would you do? Clinicians in the room. Based off everything you know today, what would you do to try and help this weird muscle test that doesn't have a name that we found was weak?
You could adjust the...
You'd what?
You could adjust it.
You could adjust them. If that's within your scope of practice, just roll them on their side, move, make something happen, right? Mm-hmm. That would be an option. Anything else?
Try one of those.
Potentially create an afferent stimulation through the taste receptor. Anything else?
Whistle Dixie.
Whistle Dixie, see if it's a right brain issue, right? Right? Count backwards, see if it's a left brain issue, right? Something like that. Have him jab on something. So for Liz, we had her jab on her SI joint on the right side, that little dimpley area. And we said, what if we create some stimulation here? Does it make a change here? And it didn't. So then we went to the other side and said, all right, jab here. Maybe it's the opposite side. And that didn't. Then we changed her pelvic tilt. I put her on a little block and rotated her pelvis a little bit and just let her rest into that block. And that made the change more appropriately. So we said, okay, maybe there's something with the tailbone that's still off that wasn't quite SI joint, but had to do with something with pelvic rotation. And because I'm a chiropractor, I flipped her over, did some stuff structurally to it. We tried it again. It didn't work. Flipped her over, did something different to her, flipped her back, and then boom, it worked. And it was just real-time troubleshooting of a problem that we identified accidentally while workshopping. Okay? But I tell you what, and guarantee, no one else she's ever been to has ever done that to her before. Guarantee it. Because we often get into a routine of, I'm going to look at your x-ray. Your x-ray shows fine, no cancer, no tumor. I'm doing whatever physical evaluation of range of motion, whatever, and you have decent range of motion. So I'll just adjust you 3 times a week for the same way for 6 weeks in a row, and we'll just see what happens. And I propose we can look at the body differently than that if we're structurally based people. You know, there could be all kinds of stuff that goes on to make this happen. And that's why we went to our paradigms of health earlier. It could be a blood sugar problem, it could be a gut problem, it could be an emotion problem, it could be an infection problem. She could have autoimmunity, she could have surgery, she could have all kinds of stuff. We just make up whatever she's got. And that could be affecting what her leg's doing. And it's up to me as the clinician to try and figure out how to help that person resolve their concern. Does that make sense? Yes, ma'am.
So, I mean, we're using these
Set up for me.
tests.
You can just
It's
sit down.
not like they came in because my leg is weak, right? But we're using that particular sign to help us come up with something that's making the body work better overall so that it will potentially positively affect what they did actually come in for?
Sometimes yes, but sometimes they come in because their leg hurts or is weak or it doesn't work in there. So today at 1:30, I asked some patients to come up, and I'm just going to show you what it's like for me to just treat somebody. Like, we'll ask them to give a quick history. People that haven't been touched or worked on at all today, they're just going to come up, and we'll say, in 3 minutes or less, tell me everything that's going on in your life. And they'll just tell you. And then you'll watch me just muscle test the snot out of them and see how I might clinically work through some stuff. And I'll just talk out loud as I go as fast as possible, and in 15 minutes or less, we'll do an office visit for that person.
Okay.
And we'll just see what it looks like. In this scenario, it's weird because you're not necessarily presenting with anything, and nor do you know the history or the status of people. We're just learning concepts and skills for you to be able to say, all right, in the hypothetical situation that someone comes in and has a back problem, I might start with some of these tests and see if any of these muscle tests show up. Then if this hypothetical patient that comes in with this symptom that makes me think of these tests has something going wrong with them, I now have clinical tools to be able to use a nutritional or a structural or an acupuncture or an emotional or whatever thing to try and help them get better. Right? So right now we don't have a like real life application because we don't know what it's like yet to interact with someone. We just know what it's like to test some muscles, put some things on your mouth and see if the muscles do what they're supposed to. We know how to palpate on someone and find pain, but that pain may be irrelevant to why they're presenting to your office. But in a real life scenario, when someone walks in on day 1 and I've got 10 pages of paperwork in front of me, and I've got their lab tests, and I've got them telling me they want to feel better, I can quickly assimilate that information and say, okay, she has headaches, she wants to lose 10 pounds, she doesn't have the energy she wants, her cycle's a little bit weird, it bleeds this way, and she has breast tenderness. Where do I start? Well, I start in a very systematized way where I start with palpation, because we saw earlier that if I jab on a gallbladder, or if I hit an enzyme that has to do with blood sugar handling, those imbalances could lead to hormonal compensation. And it makes sense for me to clinically and relevantly go through that with someone. Now I'll still look at range of motion, I'll still test some things, because maybe they just need their neck popped. And I can pop necks, it's great. and it'll help with their headache. But if their headache is because their estrogen is imbalanced or their blood sugar is unstable, and I refuse to look at those things, I'm missing the boat with that individual. And yes, I'll see them and I'll crack their neck and I'll make them a great patient because they'll love what I'm doing. But I potentially could do more for them by knowing more about them. So I measure a ton, and then I see how it consolidates down into a moderately appropriate program for them, which usually means we're modifying diet, we're taking supplements and herbs, we're seeing me for structural and neurologic care, we're following up as needed. We'll retest some other things in the future if necessary. Does that kind of make sense? But a very, very common presentation from someone in my office is, I get headaches, my cycles suck, and don't have the energy I want, and I want to lose some weight. You'll see that every single day of your life with every person you ever interact with. So now how can I do that and give them more than the 2 chiropractors you had to pass through to come see me just in this building alone? Why would they go see them instead of me, or me instead of them, right? I'm giving them something that they're not getting anywhere else by looking at them in a way that nobody else is. Does it kind of make sense?
Mm-hmm.
I guess there's only one chiropractor now because the other chiropractor moved out last week, 2 weeks ago or something like that. But it's the same concept. Like you're from College Station and you drive to go see Jackie where?
Awesome.
How long does it take? 2 hours to come from your home to get to see that amazing clinician in Bee Caves, Texas, because she does something that helps you that no one else has ever helped you with. It's kind of a big deal. You drive how long?
2 hours.
2 hours. How long do you drive to come to my office?
An hour.
An hour? Because you just live in Katy, so that's easy, right?
Well,
So-
Fulshire now.
Well, Fulshire,
So now
so,
I'm thinking a little bit, yeah.
right, a little bit, right, but it's no big deal.
Yeah.
People come to our office all over the place, like they fly in.
They fly in.
There's a guy that sees me once a year from Saudi Arabia. He comes
Yeah.
in every year and he sees us in Saudi Arabia. He calls in, scheduled an appointment maybe 3 weeks ago, 4 weeks ago, and says, what labs do I need to update for my appointment on February 15th before I get there?
Yep.
And so I'll send him a requisition.
24 hours of travel.
Yes.
Yeah,
Yes.
I mean, he comes for other things at the same time, but he guarantees that he's going to be in my office and he'll book out 4 months and 5 months, however long it is,
Yeah.
till February in advance to make sure that I'm in town, he's in town, and then once my appointment is scheduled, he books with everybody else and says, that's what I want in my
That's
life.
because we're more than just a skeleton.
That's right. That's right. We have so
that's,
much to
that's
offer
all
people.
you're addressing here. We're more than a skeleton.
So big deals. The people that are going to come in, they came in because they were looking for someone who does muscle testing-y things. So we'll let them talk about people they've seen versus people they haven't seen and why they chose this style of care for their lives. But no, it's great. You'll love it.
Yeah.
Based off of everything we've gone through so far, what questions, if any, do you have about the concepts we've covered? Because we've gone through how to identify a correctly testing muscle that's normotonic, how to resolve it if it's hypertonic or hypotonic, hopefully in at least a couple of ways. We've talked about palpation and inflammation as it comes out from it. We talked about ways to stimulate the afferent system or giving a sensory input through taste or through touch to change range of motion, to change muscle strength, to change pain. Is there anything that we're confused on before we call it good for lunch?
Is there patterns of finding a muscle that's hypotonic and then finding a common compensation that might be hypertonic?
Sometimes. There should be, but not always. So let's pretend I have a hypertonic bicep and it doesn't go weak when it's supposed to. We would assume that the antagonist muscle, the opposite muscle that does the opposing action, should be hypotonic when doing that. And if the body systemically is neurologically sound, that will work. If there's other stuff gumming up the system, then you'll find weird screwy things because there's something else going on. But yes, technically that should be the case. If you get bored later and come look through some of these books, let's see if this has it. For example, by grabbing this book. The big, thick blue ones should have antagonist muscles listed with every one of them also. So you find like the psoas muscle, and it'll say, okay, the psoas is in abductor and flexor. The antagonist muscles should be the glute and the TFL, and it'll go through and it'll talk about some of those. And if you look at my chart in that third room over there, you'll see reactive muscles on one of the lists there, and you're like, so this one is reactive to this one, and they talk about that. Any other thoughts? But that's only assuming someone is appropriately
Yeah.
organized within their nervous
That was
system
the
and
only
not
problem that
compensating
they
from
had.
anything else. I'm sorry?
Which they're not usually.
Some people are. Some people aren't. Okay? Any other thoughts or questions? I know for some of us in the room, this might have been way over our heads at the beginning. And hopefully it's not so anymore. And some of you may have been like, oh yeah, I remember those words. I've taken an anatomy class before. I just never tried to put it in an application or in a usable format. So when we come back from lunch, which we're going to start again at 1:30, we're going to have 2 people that come in, probably. And I'm just going to demonstrate what that looks like for a little bit. And then the rest of the time, we're branching away from the basic science portion of manual muscle testing and diagnostic activity. We're just going to move out and expand our thoughts a little bit. Cool? Alright, so that brings us to the last question. And that is, sorry to put everybody on the spot, but would y'all like to do something as a group and just go eat somewhere? Or does everybody want to do their own thing and just meet back here whenever you want at 1:30?
I'd rather do group. You wanna do group?
See what I mean? Okay. So if the group option is an option, do y'all want to go to like hippie type restaurant that has crunchy, good, gluten free, all that type of stuff, which is further away and taking us a long time to get there, which would be called Bella Green?
Oh, I love that.
It's about a 15-minute drive from here. There's nothing close that's like healthy-ish.
There's nothing close healthy. Gyro King's question.
Yeah, I was gonna say, if we need to do, there's a couple Mediterranean-ish places that are fairly quick.
There's a Salada too.
There's a Salada that's also like 10 minutes away, which is a salad place. But if we're going like, we want gluten-free, dairy-free, hippie, crunchy options, it's just like a 15-minute drive and it just might take a little bit of time. And we just need to be back by 1:30. But we got a little bit of time. That's an hour and 40 minutes
I
or so.
defer to you guys.
I'm gonna have to ride with you because I'm
We're 15
Carlos.
minutes from everywhere, so that seems like
Are you saying from the
Okay.
jump?
15 or 50?
Is
Yeah,
that fine with
50
everybody?
or 15.
Alright, in that case, if you pull out your phone, whoever wants to can join us. We're gonna go to Bella Green. And
It's so good.
Bella
It's so
Green
good.
in the vintage is the one we're going
Do
to.
they have curry of any kind?
I took you on.
I don't know if they do.
I don't remember.
Can I ride?
No, that was the
and I
well.
can take as many people that wanna go. I know what it is.
This is
So
making
it's
me
Bella
very
Green on
excited.
Luetta is the one we're going to. In the vintage.
Well, I don't have to drive, so I'm gonna go to bed.
I technically have room for 1, but oh, you
It's
drove
only
your
5
car.
miles.
I brought my car. I
Yeah,
took
but
me
still.
and Kyrie.
17 minutes away. That's right. So you can drive. So I have room for 2.5, 3 people in the backseat of my car.
2.5.
I mean, 2 people comfortably. Someone else might be able to drive there. So Bella Green on Luetta is where we're going. It says we're 17 minutes away. Our goal would be to get there, get back, be here by.
Yeah.
All right. Everybody like Bella Green?
Yeah,
bad.
they're so
It's a good
good.
place. Pretty much anything there that's fried is gluten free, so it's always kosher for like the kids if you need to, for normal people too, even kids. But yeah, it's good stuff. So we had some conversation over lunch where we were talking about how does this potentially become clinically relevant and not just, it's a neat parlor trick to test someone's leg and then make it go weak and something like that, right? We talked about how important it would be to know about someone by doing like a case study or clinical history or questionnaires or something like that. And so therefore, to kind of see it in real life, we invited a real life patient
Test on me?
to come up and see what it looks like. I think we're gonna try to do it here. And if for some reason this table gets too sketchy, because I need to adjust something or whatever, we'll just all go into my room instead. It'll probably be fine. So that's one part of it. The other part was there was some debate or question of like, how does this work within scope of practice? If someone comes in and they report that they have back pain, why do I need to poke on their belly and see if their enzymes are working right or if their stomach's doing well? We talked a little bit about viscerosomatic reflexes, on how it's possible that the symptoms they're experiencing are recurring out into the low back. But it's also possible that they just have a back problem that needs to be adjusted or messed with, right? It's okay to be one or both, or none of the above. They could have metastatic prostate cancer, and that's why they have back pain. And you shouldn't be adjusting them, and you possibly could try and support their dietarily and nutritionally anyways, but they probably need to be seeing another doctor at the same time, right? So it's a little bit of using your clinical judgment as to how these are going to be thrown in and out of the patient visit. So in the state of Texas, we handle something called the vertebral subluxation complex, which means when a nerve is becoming dysfunctional to some way, shape, or form, and it manifests as a symptom elsewhere, if I can trace that symptom back to the nerve and the spinal complex that's imbalanced, I can do something to support that person, right? So, keyword there would be support the individual, not treat the condition. And that's a nuance of terminology that allows you to best help someone. So if they come in and they have metastatic prostate cancer that's gone to the lumbar spine, and they say, hey Chase, can you help me? The answer is maybe. Let's do an exam. So I do a history, I do a case workup, I do an exam, I do everything I'm doing, and I find whatever I think I need to support and help them with. Am I now treating them for their metastatic cancer? No, I'm treating the individual that happens to present with metastatic cancer, and I'm doing that by staying within my scope and modifying their diet, supporting their immune system, doing whatever they need to do, while the oncologist is doing what the oncologist does in their scope of practice. Does that make sense? And together, we work our magic, and hopefully that patient responds well. And so, just because I'm a chiropractor doesn't mean that I have to just treat neck pain, back pain, or headaches. We can do other things, and I can support the process with individuals that have bigger and fancier diagnoses than car wreck, right? But we potentially get into a pickle if we start claiming to do things that we're not supposed to. Like, oh wow, your glute medius went weak, maybe your prostate's inflamed. That's a weird thought, right? Because we talk about glute medius being potentially associated with reproductive organs and glands. It could mean that, but it could also mean a bunch of other things, like you just have a hip that's not working right. So if I test this glute medius, and then I put Simplex M in their mouth, and that glute medius tests better, that doesn't give me a diagnosis. If I wanted to diagnose someone with a prostate issue, we could refer out for a digital rectal exam. Unless you're froggy, feeling froggy, you do it yourself. But, we refer out to the appropriate examination for the appropriate diagnosis. But we can still support the imbalances that are being manifested at the same time. Does that make sense on how we can support people rather than treat people? And the fine line that comes between both of those while staying within scope of practice. So in my brain, I've conditioned myself to never say, I'm treating this. The word treatment never comes out of my mouth in my office. What are you doing today? I'm supporting your liver. Why are we doing this blood test? I want to evaluate what's going on through these aspects of life, and we're going to support the condition that appears to be present in your body. You appear to have blood levels consistent of that with someone that has diabetes. I'm not diagnosing the diabetes, I'm not diagnosing the liver failure, I'm not diagnosing the symptom by saying, you have this, let me put it in your chart. But I will say, they have labs consistent of someone with diabetes with elevated blood glucose, elevated triglycerides, elevated hemoglobin A1C. We supported their body through dietary modification of lower carbohydrate diet, reducing saturated fats. We supported their body through nutritional interventions of AF beta food, Diaplex, Simplex M, and Tonkat Ali, just different herbs or things like that. And we're going to follow up again in a week to see how their back pain is doing. Does that make sense? Like that might be how I might write it out, or my care plan with the person, and then we'll retest labs in 6 months. Cool? And then that's the way I see people. And it's not me treating them for that thing, but I fully expect within 6 months of someone lowering their carbohydrates, taking the supplements, getting their neurologic system recalibrated through what I do in the office, being compliant, that they're going to stop having pancreatic things show up on their physical exam, that they're going to that they're gonna have stuff not present in the way that they presented when they came in. Does that make sense? So what might this look like in real life? We have a real life patient. Have a seat here for me. And as if you've never met me before, and you're now telling them what brings you to the office. Tell me a little bit about what you've done in the past, to how I can help it and not help it. what are you doing currently to try and just be normal, natural, and healthy, whatever you do, and just kind of give everybody 3 to 5 minutes of a personal medical history, and then we'll just go from there. You
Okay.
can say that you've seen someone who's brilliant and amazing, that's fine.
Yeah.
But just the process of like what you're doing
But
in
now
your
I
life.
came to someone even more brilliant and more
Exactly,
amazing.
right,
Got it,
yeah.
got it. All right. Hi, I'm Mitch. There's a lot to start. There's a lot to go back with.
People are complex people.
People are complex people.
Why did you come see me originally? Let's
Yeah,
start there.
yeah. That's what
What's
I
your
was gonna-
primary chief complaint for why you came to my office?
Back pain, discomfort. I spent my better part of my life in sports. I wrestled for a long time. I've had knee surgery. I've had shoulder pain, back pain. I have carpal tunnel in my wrist. So I'm just kind of all messed up. Obviously, the neck is very involved in wrestling. I'm not in daily pain or aches, but overall it just becomes worse. I spent many years working. I was a paramedic. I spent many years on an ambulance. Lots of lifting, lots of carrying, lots of stairs. That was gruesome, jumping in and out of ambulances. Now it's not much better because I work from remote and now I sit behind a desk all day. So I'm constantly hunched over and I got a standing desk that I don't use because it makes too much sense. And I've been to chiropractors for a long time. I believe in chiropractic medicine. And it wasn't until I was muscle tested for my appropriate ailments that I actually got the care that I needed. I felt like every time I went to chiropractic, it was a cookie cutter method of approach to the patient. I felt better temporarily until I had to come back the next week or in a couple days, and I was back to where I started. So I think that's about it. I think through this I found a lot more. Found out a lot more about myself and my body through I don't know what you want to call it, naturopathic medicine, holistic medicine, muscle testing. I think muscle testing allowed me to know a lot more about myself and how to treat myself through diet, through exercise, through various approaches that actually helped my overall state, that helped my neck and my back. I actually don't really have shoulder pain anymore. Before I wasn't able to, whenever my muscles were engaged, I never really had pain. But if I was like holding a bag of groceries and it was just kind of like without any muscle use, just kind of laying there, I would go numb. Like I would have a lot of numbness and tingling here, and it would just go all the way down to my hands. Thought it was my shoulder. Through chiropractic, I found out it was my neck. They fixed my neck, and this went away. It still comes back every now and again, but then I consistently come back here to make sure that doesn't happen. Yeah, I think that's about it.
Cool. If you were going to touch the one spot on your body that bothers you the most today, where would you touch?
Probably like back here.
Okay, so like C7T1 area.
Mm.
Okay, no numbness or tingling today?
No.
Okay. You've seen muscle testing people in the past. Your uncle-in-law
Yeah.
practices AK
Yeah.
in California.
Mm-hmm.
That's where you were first introduced to it.
Yeah.
And so went to regular chiropractors, had positive outcomes with it because you're like, hey, I feel better, though it comes back sooner rather than later.
Yeah.
And then you meet this guy and he starts testing you a bunch, and it was weird at first. And
It was wild because he, was muscle testing my legs, and he's like, yeah, I need to adjust T4, and I'm like, what? I'm like, just that vertebrae. He's like, just that, and he just adjusted T4, and I felt phenomenal, and I was like, I don't understand what just happened, because it's always been just as much as you can crack all at once, and it was never targeted until I was introduced to AK. Yeah.
So no digestive issues going on right now. Energy's good.
Energy good. I did
Pancreas is great there
I
now.
did have some GI upset probably 3 days ago now.
Mm-hmm.
I think it was my dietary changes. Somebody really mean in this office told me I can't eat carbs anymore. So otherwise I get a hole drilled into me every time I'm here. We might go into later. Yeah, otherwise I feel okay. I'm stiff and I'm tight, but I don't feel pain.
So some stiffness and tightness, no major pain, but if we were going to localize, where the neck meets the
Yeah,
upper
'cause
back.
as you can see, I'm sitting like this, and I always do.
Digestion's not too crazy today, but was a little bit wonky earlier this
Yeah.
week. No numbness and tingling. Sleep's been decent. Energy's been decent.
Yeah.
Urination's decent.
Mm.
Respiration, you're not short of breath or anything like that. So,
No.
so does that make sense? We just did a quick history. Hypothetically, we're writing all this down, and we know more about him now. But if you, the clinicians, are now thinking, what do I do with this? Like, in chiropractic school, it's defaulted, well, it's time to adjust now. You told me a bunch of fun things, it's time to put some joints back into place, and we'll see how you do in 2 or 3 days. And we just start that process. But now we're looking at things through a different model. He told us a lot of things, many of which are still musculoskeletal in nature, though could be referred from other things. So we're just going to jump right in and start testing things. So lie on your back with your head over there and your feet over here. And this is straight up what we do like every time. He tells me what's going on. I usually write things down. I do what I need to, and then we go on to the next step. Bend your knees for me. I'm going to do some tests that we did today. And I'm going to do a lot of tests that we didn't. So you'll just see what a normal visit would look like as you become more proficient with manual muscle testing, using it through diagnostic muscle testing as taught by Applied Kinesiology. Right? Alright, squeeze your knees together. Good. Push out for me. Good. So I'm just getting baseline squeeze. Stop. His pubic bone keeps clicking. That's why we're testing this a few times. Squeeze again. Okay, good. I'm going to poke on your belly here. Anything hurt when I do this?
No.
Have I done this to you before?
Yeah.
A lot or
Yeah.
occasionally? Or
Yeah.
once? Any pain or discomfort when I'm doing this?
No.
So, we went over stuff like this before. We're just looking to see is anything hurt or uncomfortable, especially because you mentioned possible digestive stuff over the last, 3 days ago or something. Not too bad. We go deep in the corner, hit that ileocecal valve, no problem. No pain, no discomfort through any of this. Through the belly.
No.
He doesn't have ovaries, so we'll skip that part. I'm going to jab you in the chest. No pain, no discomfort.
No.
And I'm going to jab you in the face. No pain, no discomfort.
No.
So, luckily, nothing hurts through these viscerosomatic places where we were looking for palpatory pain, which is a good start. So now we're just going to test some other things. Hold your feet up and to the outside, just like that. This is a peroneus-based muscle. Good. Toes toward your nose. It's just toe extension. This is like S1, now L5. Relax here for me. These are kind of myotomy, but kind of not. Oh, hold that again for me. All right, we got something that's wobbly. Do this one. So that one's locked solid. Hold there for me. That tibialis anterior over here feels different than this one. Does it feel different to you?
Yeah.
Hopefully I'm not making things up. Here we go. His belly button is an anatomical landmark for about L3. So I'm going to come have him jab at about where the nerve root comes out to talk to this muscle here, because I'm looking at structural neurological things, right? So now hold that there. Don't let me move it. There we go. That made a difference. So that makes me think maybe this nerve, through the vertebral subluxation complex or spinal manipulation issues, that nerve may not be communicating down to this muscle like I want. So I'm thinking chiropractically first, because that's my job. I have to make sure and tie things back to the musculoskeletal issue. If we had my applied kinesiology chart, we're going to go get it off the wall. Don't break it, it's a big old glass thing. This chart is going to have a bunch of muscles on it, it's going to have a bunch of nerves on it, and a bunch of organs on it. It's going to show some of these relationships that we're thinking of. And tibialis anterior could be a bladdery related thing, could just be a nerve out of place here, could be a variety of things, right? Perfect. You did awesome, Pam Jam. Thank you. So this chart right here, if you just memorize it real quick, will help us know what we're doing and why. Sorry, there's a bunch of dust on top of that apparently. Tibialis anterior, if I come over here and find it, tib anterior says it correlates with this area here, and if I pull all the way over here, it says, oh, I lost it. Tib anterior correlates with urinary bladder. So I'm like, okay, but it says also possibly adrenal related stuff. So what do the adrenals do? They deal with, stress responses and hormones and cortisol. But in my mind, I'm thinking, we've got this nerve that's not working quite like I want it to, but I can think maybe bladder, maybe adrenal, maybe bone out of place. And it just starts running through my brain as I'm thinking of this. Hold there, don't let me move it. I retest it. Yeah, still not working like I need it to. I'm going to ignore all oral testing right now because I want to know more about him. And so I test other things. Sorry, I'm still down here. So I would have just finished that one. Now push to the outside. There's our glute medius that we talked about. Do that one more time. That doesn't work. Push that way. one does okay. And this one, push out, glute medius, doesn't work. Push up and out, tensor fascia lata, that one does okay. Up and out, tensor fascia lata, very good. Leg straight, press up to the sky, good. This leg straight, press up to the sky, good. Are we doing what we want to do? Push up? Yeah. So far nothing seems weird. You know, I found a weakness, I found another weakness. They share similar relationships, kind of, but nothing looks too crazy. So we're just checking things. Come to psoas, press up for me. Iliacus is way out here, now push up. Okay, good. Come to this one, push up, good, and here, push up. Good. Grab the table with both hands, push both of your legs that way, toward the TV,
Alright.
and hold. That doesn't work. Push both of your legs toward the people. That doesn't work. Hold your legs just like this, legs straight, press up to the sky. Okay, that did okay. So far we've got quadratus lumborum on both sides, glute medius on this side, tibialis anterior on this side. Everything else appears to be more or less okay. Arms straight, bring this to your side. Good. That's a that was a lat muscle, push that way. There's pec clavicular division, push here. Sternal division, bring this to here. Costal division, that doesn't work. Hold. And that changes. Now, push that way. That's rock solid. Bring this to here. Good. Bring this to here. Okay, good. In a perfect world, I'll do it from the other side, but I'm trying to walk around the table. Good. Now push toward me. Good. This arm straight down to here. Good. This down to here. Oh, we got two of them. That's exciting. All right.
You know how much joy comes over me when you find something go weak?
So we're just finding stuff. But I mean, we're like, how far are we into this visit? Like
A few minutes.
3 minutes maybe? And I'm just testing a ton of stuff. I'm just getting brainstorming ideas. Finding as quick as I can. None of this makes relevant sense yet to the discomfort we feel here. Some of it could be for just low back stiffness and whatnot, because we have some hips that just aren't working right. If feet don't work properly, knees and hips are going to compensate biomechanically to try and stabilize in other places. So there's some biomechanic rationale for why I might want to make some changes. But I'm screening through on his body to see what's working well and what's not. Squeeze here. Good. And squeeze here. Good. Lift your head up for me. And press out. Good. Relax. Make a double chin. Lift up. And hold. Good. Relax. Lift your head up to the sky. Now lift up. Okay, good. Because you have specific symptom there, arms straight, push down to the floor. There's a middle trap that doesn't work. And that's a specific muscle I want to test because of his complaint. Push down. And that does it on both sides. Okay. Muscles we have weak so far. Tibialis anterior, glute medius, bilateral quadratus lumborum, bilateral pec major, costal division, bilateral middle trap. We'll stop there for now as part of our visit. Some of those have some overlap, some of them really don't. The costal division of the pec muscle and the middle trap comes to this spot sometimes as a neurolymphatic point, so a place that correlates with spleen and pancreas. The tib anterior, like we talked about, might be adrenal, might be bladder. Glute medius we saw earlier could be reproductive organs, could just be hip out of place, right? We don't know any of these things. Just out of curiosity, what's our favorite pill for the day? Beta food. Take this,
Makes everything better.
place that in your mouth for me. Oh, we lost it. We'll get that one later. Now put that in your mouth for me. Real life, this is what I do with
Feet.
I'm sorry?
Feet.
Okay.
Thanks for giving me one that doesn't taste bad.
This is the one I want people in your family taking right now. Hold up and in. That's better. Push out for me. That did not change. Hold the table with both hands. Push that way. That did not change. Push toward the TV. That did not change. This arm straight. Bring this down to here. That's better. Bring this down to here. That's better. Push down. That did not get better. That one probably didn't get better. So let's put that out. Alright. That was a good thought. We're going to go to Diaplex now. AF beta food, the reason I jokingly tell everybody they need it, and it's one of my favorites, is because it's just so broad in application. Helps with blood sugar, helps with liver stuff, helps with kidney stuff. Hold. Good. That's better. Now push out. Try that again. Diaplex. Yeah, that's better. Grab the table with both hands. Push both of your legs that direction. Good. What are we seeing about this one so far?
Looks like
Shall we?
good. Like a winner.
Doing better, right? Why might we come to Diaplex? Bring this to here.
I don't know what's in
Diaplex. It's a blood sugar stabilizer. And he just told us earlier that some mean person made him stop eating carbohydrates. Push down for me. Because he's routinely showing up for blood sugar related things. Push down. Good. Just out of curiosity, does that hurt at all?
Yeah.
Like on a scale of 1 to 10, 10 being the worst, what is that like?
Like a 3.
Like a 3. Spit that out for me. With that not in your mouth,
Yeah.
what is that like now?
Like a 7.
Okay. So we just did that reflex in reverse. He just happened to have it in his mouth. Everything was strong. For him, he would find value in something like Diaplex. And so if this were a real patient visit, I'd say, you know what? Your blood sugar stuff is doing better than it used to be. You're avoiding things that taste good, which is great. Keep avoiding carbs. Keep doing that. But because you had some stuff showing up, we might need to add something like this into your life. But now I'm going to do some other stuff because I like to adjust people. So now I'm going to adjust him, right? And it might be weird because you just saw me test muscles that didn't apply to the 10 muscles we learned today. But the application is similar in a sense that I can find a muscle. If it doesn't do what I want it to do, I can go to the reflex that correlates with it. I can put something on the tongue that correlates with it. I can look to his neck or his back that correlates with it, and I can try and make change. Right? You okay if I adjust you real fast?
Yeah.
All right. So you lay facing that way. We're going to see if this works, or if I break the table and we all fall over each other.
It is what it is.
It is what it is, right? So we're just going to adjust this L4 real fast. Relax that like so. Yeah, grab your elbows.
Yep.
Something already clicked at something.
Yeah, did.
Good. Come on your back.
Table's busy.
That wasn't too bad? Yeah, no, the table, this is
It's
not
okay.
an adjusting table.
That's how it's supposed to be. It's supposed to do like that.
Alright, so we moved his lower back. Hold that there, don't let me move it. That's better. Now push out. Good. So we turn on the lower half of him by putting in the correct spot in his back. Arms straight, bring this to here. That's still wonky. Push down. That's still wonky. Turn your head all the way that way for me. Now push down. That made that better. Keep your head looking that way. Now bring this to here. That made that better. Keep looking that way. Bring this to here. Good. And then push down. So if he always looks right, he appears to work okay. Turn all the way this way. Bring this down to here. Okay, that didn't do it. Push down. So, something through his afferent nervous system changes his efferent presentation when he's looking to the right. Because it's easier for him to touch over here, one finger, which is start with that top bone and just hold that right there. Now bring this down to here. That's not the right spot. Come down one. And now bring this down to here. There it goes. Keep touching that spot. He's on about C2 on the left. Push down. That's better. Good, relax. I'm going to do it this time. Push down. So, if you were playing doctor, where would you go? I'd go C2 on the left, right? And we're going to put that bad boy in place. Just relax. Go to happy places. Good. Alright, now push down. There we go. Now bring this to here. Does that make sense? How we can identify where we want to go and why we want to do. Rather than make a bunch of noise, which is fun, we can be more specific and accurate in what we're doing. We turned on the muscles that are going on, just out of curiosity. Is that uncomfortable?
Not as much.
What is it like now?
Like a 3.
Like a 3.
2, yeah.
So this is like what it was whenever you had that in your mouth. And all we do is adjust your L4 on the left and your C2 on the left. Put that in your mouth again. With that in your mouth. Did it make a change?
Yeah.
Same, better, or worse?
Better.
Like to what?
Like a 1, barely.
Barely. Cool. So Diaflex wins. Carbs out of your life. We moved the specific things that were necessary and required for you to function better. Liz will take your money at the door. No, sure. Does that kind of make sense on what a normal visit might look like? To couple in our scope of practice, which is structural-based things, nutritional support, manual muscle testing to identify where we wanted to go. Now the hardest thing for some people, as you will have noticed, that I didn't really palpate a ton. Like I didn't go through and look for segmental mobilization. I didn't do range of motion with what I was doing there. I let his nervous system direct me what I was needing to do. Right?
Okay.
Not yet. We're gonna do more fun stuff. I want you to go walk to the end of the hallway and back, and then we're gonna come back. Or like down to the restrooms and back, just halfway down. So why would we have him do this, right? So sometimes normal life jacks people up. What if his walking gait mechanics are enough to cause the tension and tightness in his body to recalibrate and jack everything up from what we just fixed? So he tells me, hey, I felt really good on your table, and I walked down. By the time I got to the car, it felt like things were just back again. So I will often have people stand up and walk around for a bit, and then come back and retest some things to see if we corrected it. So that's what we're doing right now. Is this boring?
No.
Could you see this in real life as possibly in an application? Not too crazy yet?
Was the place that you touched not part of the initial palpation?
It was not.
No.
So I was doing on the ridge line here. That's going to be seventh intercostal space on the left at the area of the nipple. So I was a little bit off of that. You did great. Land your back for me. Grab the table with both hands. Push both of your legs that direction and hold. Oh, snap. He's already broken. And it took him 100 steps or less. Push that way.
Stop breaking yourself.
Push out to the outside. Hold your foot up into the inside. Isn't that weird?
So just stop walking. Check your wheelchair.
It's over. You're dead.
All of our work in vain because something is still blowing his circuit out after just a little bit of walking around.
You need to actually
as
take that
cool as
back.
our demonstration was, he's right back where we started. So how do we correct something like that with individuals? You're okay to stay like that for a minute?
Yeah.
Up to this point in the game, we've demonstrated diagnostic muscle testing as taught by the standard of the International College of Applied Kinesiology. And it's been very neurocentric. This is a neuromotonic muscle, this is a hypertonic muscle, this is a hypotonic muscle. This is afferent stimulation, this is an efferent response, things like that, right? Well, as we do these things, we can have a lot of insight into the body. But sometimes, either based off of time and interaction with the individual we're helping, or with the complexity that comes from the human body being the human body, we might feel like we're stuck. So this was a perfect example. I'm glad you happened to be presenting in this way because I was going to dismiss you and if everything was fine and we go on to the next part of our class. But if you got a little bit of time, we're going to go through some other weird stuff.
Sure.
So, we've only been in this category of what are we doing with professional applied kinesiology criteria, standard of care, right? Because we need to be able to have the reproducible nature of if I work on someone and they go see someone in Las Vegas, that person has a similar concept of what's going on. Just like if you go to one OBGYN here and you go to one in Las Vegas, it's a similar-ish experience. Doctors can say the same words, they can interact with the patient in the same way, they know standard of care. The International College of Applied Kinesiology has attempted to do that, and that's why there are textbooks over there on the wall. There are other versions of muscle testing, though, that you may be familiar with. And this is where the chaos comes from chiropractic school specifically, is other systems, which are adaptations of manual muscle testing techniques, sometimes are perceived as weird, out there, strange, something, because they're harder to replicate between practitioners. They can be very useful tools, though, as we attempt to look at the body in a slightly different way. So, one of the concepts that I would strongly kind of hone in on here is a lot of other muscle testing systems rely on group-based testing rather than isolated individual muscle tone, and they're often associated with the energetic systems of the body, whether it's the acupuncture system or the superficial reflexes of the body or things like that. So just to reiterate this previous slide from earlier, muscle testing tells us that something has changed. It hasn't told us what has changed or why it's changed yet, but we know that something happened different, right? It's not always based on the concept of strong versus weak, but normotonic versus abnormal function. And so when we have someone who responded well to what we did, but then lost it in the 30 seconds it took to walk to the end of the hall and come back, it tells me there's something else going on with him that I should probably figure out. Now, it could mean that I just missed a joint that was out of place and I need to just put his knees back in or adjust his ankle or adjust a different bone in his body, and then it would hold a little bit better. But now I need to figure out how to determine that in his life. Because we went through and tested a bunch of muscles, we corrected the things that we found that were applicable to correct, but yet we still have a presentation of dysfunction. So I will dip into other versions of muscle testing at the same time that I'm doing my standard of care muscle testing things. But I just want to share this, not because this is a great website. This website is absolute garbage, because they're anti-everything that actually helps people get better. But there's this website where this guy, it's called Quack Watch, and ChiroBase is a subsection of that, where they basically don't think anything chiropractors do is of value. And it's all smoke and mirrors, it's all mysticism, it's all worthless, is the premise behind this guy's website. But he just happened to have talked a lot about applied kinesiology at one point, and the International College of Applied Kinesiology created a response, and in that response, this is a section of it that is worth noting, that just talks about standard of care applied kinesiology versus other systems of muscle testing that aren't standard of care, and how it's hard to judge one versus the other because they're not the same thing. So if you get bored, you can always look through that. You all got the slides. So we're going to look at something with, like we talked about before, autogenic inhibition. Kim, we go into my room and grab my big bar magnet and one of the round magnets off my arthrostim stand. Thank you. So we saw earlier that when we take a muscle and you push up, it's good and strong. We can inhibit that muscle temporarily by using autogenic inhibition. That's the neurologic rationale for what we're doing. We're going to show you a different version of doing that, and then we're going to start scanning his body quickly to find a muscle that might be misfiring, which in turn causes things to get jacked up as he moves. So we're going to do this with magnets though. So, large magnets on the arthrostim stand, they're attached to the side of it. Very large magnets, like 6,000 Gauss or larger magnets, seem to affect the body in certain ways. We'll just go with that for now. If I take a large muscle and you push up, good, and then I take the north pole of a large magnet and place it on the muscle belly, I get weakening. This seems to displace the polarity of the nerves as they interact with the muscle, and therefore I can do a screening tool very quickly with the magnet that does not involve me muscle spindle celling or doing other things like that. Thank you, Cam. So I have magnets, large magnets. The north pole of the magnet will shut it off. And it will do this with every muscle and body squeeze if that muscle is working properly. Squeeze here. Good.
Turns
Squeeze
jello.
again. This arm straight.
Unless you're broken.
Push that way.
It's like everybody's
Good. Try
kryptonite.
again. Good. Bring this down to here. And I can now screen through very quickly and see what's working well and what's not without jabbing on muscle bellies. Bring this to your side. And I can try and hone in on figuring out why, hold that for me right there, his nervous system shut down so quickly, chin up to the sky, hold that there, when it shouldn't have earlier. And then it's goofy feeling. And when y'all play with this in a minute, it's going to blow your mind when you just start putting magnets up to certain parts and see what happens with it, right? So we're just challenging different stuff. Hold that here. To try and see why is his nervous system not going weak when it was supposed to. Push up and out. There we go. His tensor fascia lata, which we went through and screened earlier and thought was doing fine. Oh, or wasn't. What are we doing here? Push up and out. That one's good. Do this one again, push up and out. There we go. So, we did an autogenic inhibit earlier, push up and out, but that changes something when I do it with my hands, but it doesn't do it when I do it with this. It's just a different way of looking at the body. It's a different test. Similar in application, different test in practical usage. It's a way of screening the body. So for us, whenever we do this, and he holds that magnet there, hold really strong. Hold really strong like you mean it. Good. Hold that right there. Now push up and out. Push up and out. That one works. Push up and out. Good. And take this one. There's something that's off there. Push up and out. Push like you mean it. There we go. Hold that there. Now push like you mean it. Yeah. That hypertonic muscle is probably one, if not other, of the things that would slow down his capacity to hold the correction that we just gave to him. But we had to look at the body differently because a second ago when we did stuff, it seemed like everything was fine. New concept. Outside of technically the scope of the standard of the International College of Applied Kinesiology, but physiologically applicable to what we might do here. Yeah, let's do one more. So, this is going to be our next workshop to play around with, because now that we've got this muscle, push up and out, that's not doing what I want, how do I change it? What do we do?
Flip the magnet.
Possibly flip the magnet, but then that would give us the
Wrong
wrong
information.
answer, because we want North Pole to force weakness.
Always.
So if I use South Pole, I shouldn't get a weakness anyways. So how do I get him back to testing normally
Put something
by
in his
using
mouth.
the North Pole? I'm sorry?
Put something in his mouth.
Put something in his mouth. I could do the exact same thing we did before. So I might try something in his mouth. What else could I do?
Adjust them.
I'm sorry?
You could
I can adjust him. I can now kind of look and troubleshoot around and say, oh, wait a second, what if I do this and it makes it work better? Does that kind of make sense? There's one other aspect we're going to look at here. And that is, if I take a muscle, push up, and he's strong, and I use North Pole of magnet over muscle, push up, and he goes weak, that's normal. What if I put it over here, what should happen?
Oh, that's not gonna do it.
If I test this muscle, but I put the magnet over here, what should happen?
They might still be weak because it's still on the
Push
body.
up. It should be strong because it's not local to where I'm challenging the body, right? It's like if I muscle spindle cell this down, but then test this muscle, what would we expect to happen? Nothing, because it's the wrong area, right? Magnets are screwy though, because when we put them over the local muscle that's being tested, it should cause weakness. Push. But if we put it over energetic centers of the body, like where large grouping of acupuncture meridians come together, I should be able to get a global or systemic weakness. Like the solar plexus, push up, can cause weakness. The soles of the feet, push up, could cause weakness. Over his ears, push up, could cause weakness. So systemically, he appears to be testing in a normotonic way. Locally, he appears to not. Was that too weird? Relax for a second. Did that kind of make sense? So, what if, hypothetically, he comes in, and I have an arm, and I test this arm, and you push over, and it's good and strong. And I now check the local muscle, push that way, and it goes weak, and I check a systemic reflex, and it doesn't.
Check everything in its system. Maybe.
Local.
Do I want the magnet to cause weakness here?
Yes.
I do, if it's the North Pole. If I want the North Pole over that magnet, I want it to cause weakness. Do I want the magnet over the solar plexus to also cause weakness?
Yes.
Oh yeah.
I do. But if it doesn't, I'm thinking systemic neurologic disorganization issue rather than local neurologic issue. Does that kind of make sense? So now I can just walk into somebody and have a lot of information about them in a very quick test by using a magnet. Oops, sorry, thanks. How often do I test magnets on you?
All the time.
Every time. It's like the first thing I do on someone when I'm not looking at them structurally. If they walk in, they sit down on my table, I take their arm, I test a test, I put a magnet over them, and I make sure it goes weak the right way. If it doesn't go weak the way we expect it to, we start digging out systemically to figure out why, and I work systemically to locally. Now, technically with Mitch, I did it backwards. He came in and told me his symptoms, and I said, okay, cool, let's just test some things based off of the understanding of what we knew about manual muscle testing up to that point. But now I've got a different viewpoint that I could attack this problem with. The good news is, push this one, Mitch goes weak, so weak, whenever I put it systemically on him. So I know it's not a systemic thing that's causing this problem, and it's probably this, or something similar to it that makes him mess up from just walking to the end and back. So I'm gonna just locally mess with this. If I was in my other room, I'd pull out my little vibration tool machine, but I don't have that, so I like to jab people and make it hurt.
You have the handheld one.
Oh yeah, with the mini one, that's right. Mini battery powered one. New experience.
Do you put the magnet, is it on the belly button? That's like
Yeah, it's
system?
like the solar plexus area. It's belly button-ish.
Okay, in that general.
Right.
Doesn't matter.
Yes, ma'am.
So if an issue or if your muscle is
I
hypertonic,
turned it on and it's still turning off.
if the muscle is hypertonic, would that mean that your issues are kind of like hypothyroidism versus hyperthyroidism? Hold on, my brain is. So if my muscle is hyper, would that mean that the issue could be hyper also? Like, do those correlate at all?
Not necessarily.
Or, okay.
So it's a neurologic tone issue. So your brain, the master center, is trying to regulate tonus or like balance through everything. And if for some reason it can't control the information to a certain area, it can misfire and over excite or make the area overactive so it gets better feedback to it, or it can turn it off because it's just trying to ignore it. It'll just kind of self-regulate in that way. What we're going to do here is I'm just going to fascially flush this area. Just dig my percussor thing on it and try not to break my machine.
Yeah, leg's fine though.
Don't worry about that.
That's right. You're doing great, Mitch. So Mitch is a long lost cousin. We didn't realize it until we met each other. But we are kindred spirits. And we don't know how we're related yet, but
Yeah.
we're a family. So that's why I felt comfortable bringing him in. We haven't gone fishing yet, like we keep saying we're going to, but one of these days, we'll make it work. Alright, so from just doing some fascial flushing stuff, push up and out, good and strong, hold there, now push up and out, alright, goes weak like I want, who cares? But now let's check all these other muscles that weren't working before, and push out, and they're working better now. Grab the table with both hands, push that way, good, push toward me, good. Bring this down to here. Oh, that one's still sketchy. No, never mind, it's good.
Yeah.
Bring this to here. It may call it weak. Push down. Alright,
Like, let's take it to the mat.
so all the things happened from me stripping out the fascia on this leg. Go walk to the bathrooms and back. Same place you did last time. We're going to see if it holds down this time.
It better not lose on, we're fine.
That's right. Alright, that was kind of weird to introduce that concept of the magnet. Was that too much? You can see the potential application there. In a second, when we break up, I think we've got enough magnets for every room at least. Easily.
We do.
Yeah, so all the rooms are going to have these magnets. My room has 2 of these extra. Please be careful. These things hurt when they squeeze your fingers, and these silver ones are like impossible to separate. So please don't let my silver ones get together again. So just leave them 2 silvers and a black one. Just keep them separate from each other. North pole over certain places should cause weakness. So we've learned 10 muscles. Pick a muscle that you're the most comfortable with testing, preferably one of the 10 we've used so far. Test it, put the north pole of a magnet on it, and test it again and see what happens to the local area. Then go through and mess with it through systemic areas and see if you get a difference between like over the solar plexus or over the ears or something like that. Hold up and in. Good. Grab the table with both hands. Push that way. Try that again, push. That one's still, I think I could adjust something in there and make it a touch better. But those are done okay. Push out. Yeah, I think you still have something in your lower back that's wobbly. Because it's better, but not great yet. Bring this to here. That's good. Push here. Good. Can I do something with your lower back?
Yeah.
This will be interesting. We'll try not to break the table on this one. Chin your chest. Bring your knees back toward your chest. I missed it. One more time. There it is. So that was like L3-ish. It was just above where we're twisting him through an anterior. Grab that with both hands. Now push that way again and hold. Yeah, make that better. And push this way and hold. Good. Then push out. Good. You're a new man.
Yeah. We're good.
Keep avoiding carbohydrates.
Am I done?
Yeah, we'll probably get through that. Thanks for letting me come and mess around.
Yeah, no problem.
You gonna hang out or head out? Hang out for 2 seconds
yeah.
while we let everybody
Yeah,
go to
yeah.
break and do stuff, then we'll talk a little bit more. So, the workshop we're doing next. Short workshop. Find somebody, get a strong test, localized North Pole to the muscle, see if it changes it, causes weakness. Same muscle test, see if a global or systemic place causes a weakness. If you have cell phones in your pockets, I would discourage you from putting a large magnet next to it because you will probably break something. So just be careful. Cool? Alright, ready to break. Please don't squish your fingers. Did it hurt? That might be cheap and inexpensive and last more than a month. And I think I'm up to month 3 now. So I don't know how long they're going to keep going, but they're doing okay so far. Is that weird?
That was weird.
It was cool.
Weird. It's a little bit different. It's weird.
I
You're like,
love
whoa,
it.
wait a second.
Okay, we saw a
That's the
symptom.
field that I was talking about. Electronic.
Strong with a normal test, weak with localized magnet, systemic, not as much weakness, but not as much strength.
Right? Great question. What do we do with this information, right? So part of that could be that the person is neurologically disorganized somewhere systemically. Part of it could be user error as we're learning to experiment on testing, and are we using consistent reproducible testing or not. Part of that could mean that there's something just jacked up in that individual and we need to figure out what it is, right? So therefore, once again, the question is, what are we doing with this information, right? Just because someone has a weak glute medius in normal testing, it doesn't necessarily mean that they're paralyzed, have polio, have a stroke, have a hip misalignment, need a supplement. It doesn't mean any of that necessarily. It's a tool, it's an assessment procedure to evaluate clinically what's relevant for that person's individual life and how we might support them. So in Mitch's situation, he just talked about a bunch of stiffness and whatever, but we didn't really have any symptoms that were crazy. And we went through and we tested and we saw things that appeared to be unrelated. We put Diaplex in his mouth and we adjusted his low back and his neck, and all those things that appeared to be unrelated just started normalizing. So sometimes we have to use our clinical judgment to separate the wheat from the chaff in the visit, and sometimes those things will lead us into more involved information. If I tested him and only the muscles that dealt with his gut were off, would that make me perk up a little bit rather than a bladder test and then a reproductive organ test and then a spleen test and then a, you know what I'm saying? He was all over the place with his muscles, so none of it seemed like I need to go focus in on his organ system because it wasn't telling me a consistent pattern. So I'm like, okay, that was good information to know, but probably I'm chasing smoke if I try and think everything's an organ problem, or everything's a parasite problem, or everything's an emotional problem, or everything's a whatever, right? Like, it's okay for the body to have something wrong with it, and it's okay to have multiple things that are going on at the same time wrong with it, but I need to use my clinical judgment to figure that out, right? So in his scenario, we found some muscles that were weak, and we said, what if we put something in your mouth based off of your clinical history that we know. And it made changes. We said, okay, that's cool. Then we took that out and we said, what if I pretend I'm a chiropractor and I'm going to move a joint and I have you just look one direction or another, kind of like whenever we looked and I pushed and it made things different, just similar idea. We're just using proprioceptive feedback or afferent information to see if it changes muscle testing expression, right? And then what if I have you jab on this body part and I retest again and see what happens? And we fix, quote unquote, what we found at that point. And so then we had him walk around and come back, and some of the stuff we had, quote unquote, fixed wasn't as fixed as we thought it would be. So we said, oh, that's weird. And it just let us go down this rabbit hole of thinking, okay, well, we did what looked right at the time, but now let's step back and maybe look at the body a little bit differently. Maybe there's a muscle that's misfiring and it's causing a kinetic shift through the chain that's unwinding stuff faster than he can tolerate. Does that kind of make sense? Like whatever was off in his TFL seems to have unwound what I fixed on him in the 30 steps there and 30 steps back that he took. So then I messed with the fascia a little bit and got that muscle to work more appropriately. He walked away, he came back, and it was better. There were still a couple of things that were just this marginally off. So I adjusted one more thing, and then it was better. And then I went, okay, that's probably good enough for today's visit. Let's see how it goes. And if he comes back in next time and some of those things are repeated, then I just make note of it. And I'm like, that's weird, because last week you had this off, and now this week you have this off. Maybe I'm going to dig a little bit more into why these are doing what they're doing. Does that make sense? But clinically, he's probably going to feel better. He's going to walk out, he's going to say, hey, I'm feeling good. My stiffness is less, I'm feeling better, Chase is a good guy, whatever, right? So now we've got this idea of the magnet, which kind of throws things for a loop because it's a much harder thing to describe through afferent and efferent activity and normal neurologic expression. But we have this phenomenon that means when the north pole of a magnet comes in and hits certain places, it disrupts neurologic tone. So the best explanation I think I've heard from someone, which I don't think is in a peer-reviewed journal anywhere, but it's a good explanation and it makes sense in my own brain, is that in Chinese acupuncture, meridian systems work like highways. So if you see on the bottom of this chart here, there's a bunch of acupuncture meridians labeled out, like the liver does certain things and the heart does certain things and whatever, right? And the concept of Chinese acupuncture is energy comes in through the world into certain concentric areas, cycles through these pathways, and then leaves through certain body part areas in a consistent, reproducible way. The solar plexus is a common area where people will talk about energy coming into, going through meridians, and then leaving out of hands and face and feet. So all acupuncture meridians will either start or end on the face or feet or hand. So that's why they propose that when you take large magnets, which are electromagnetic things, and you displace electromagnetic energy, like acupuncture meridians, that you get some level of reactive response in the body. Cambria, in my room, on the shelf, wait, don't go yet. First or second box on the left, there's a little black bag that says Nikken on it, Nikkon. So there's a potential that these electromagnetic things are interrupting normal flow, whether neurological or acupuncture-based flow, and therefore the body manifests as a symptom that's protective. So if my main energy source is blocked, would we expect the flow of energy going to my arm to maintain strong? Probably not. If I stop flow here, I lose flow down here, or here, or here, or whatever, right? That's the theory behind it, right? So we can use these large magnets and say, what if I just shock the whole acupuncture system? Whoop, something can't leave and do its normal job. Something can't come in and do its normal job. Thank you.
You spelled it.
Whatever. I'm surprised I remembered it said Nikken on there. So this here, you ever seen one of these before? It reads electromagnetic fields. We have magnets, and we've all seen science textbooks from like 5th grade, and they say, here's a magnet, here's the field that the North Pole makes, and here's a field that the South Pole makes, whatever, right? So this device reads electromagnetic interference. So when I come close and I throw those electrons at it, it picks it up. Right? Our body is reacting to the things that are being put out by the magnet. And if our body can tolerate it appropriately, an appropriate response happens. And if it can't tolerate it appropriately, an inappropriate response happens. Just like if I hit you in the leg and you kick, and you keep going for 5 minutes, we think, you're jacked up. And if we hit you and you respond appropriately, we think, all right, appropriate response based off of the appropriate stimulus. Magnets can do that by altering energetic activity in the body. If you want to play with this later, I'll just leave it up here. So, can I get a volunteer? Actually, Cam Jim, I want you, since you were broken earlier. Have a seat here, facing that way. Remember the things we had off earlier? Lots of gut-related muscles, lots of reproductive-related organ muscles that were off. And we said, that's weird. Some of these are just weak by themselves. So, up to this point, sit straight and tall, we've discussed the concept of manual muscle testing being specific, isolated muscles. If I wanted to test the deltoid, I would remove extra things, I'd prevent her from recruiting, I'd apply pressure, and I'd check neurologic tone. I now have learned that I can put a magnet to a body part, and I should be able to create weakness, which is normal. That's appropriate. I should be able to put it on your belly for me, in a common place that causes weakness, and that's normal. So we expect that whatever information we got earlier is probably accurate information. But sometimes you'll see in other muscle testing techniques something like this. Maybe you've seen some variant of this when you're testing someone. Which muscle am I testing here?
Depends
Delta?
on what you're thinking.
Anatomically speaking, if we only go with pure anatomy, and the arm is right here, what am I testing?
Oh, the whole arm, kind of.
Right?
Deltoid, supraspinatus.
Yeah, there's a little bit of supraspinatus involved, a little bit of middle deltoid, a little bit of anterior deltoid because it's a little bit forward. This is a group muscle test, and it's not as specific as I would want it to be if I worked for the International College of Applied Kinesiology. Because I don't get good data here because I don't know if she's recruiting or not. But it's commonly seen in other muscle testing techniques to just grab an arm and start testing. And the arm position sometimes is different. And it sometimes messes with people because they're like, well, are you pushing harder or am I in the same spot? What's going on, right? This is where art and practice comes in. Because it's hard to recreate the same muscle test over and over and over again if you're not isolating the pec major clavicular muscle right here. It's hard if you don't isolate just the middle deltoid or the anterior deltoid or the posterior deltoid. It gets fuzzy when we use long levers and group-related muscle testing. But they can be used. Not according to ICAK, but they can be used as a diagnostic tool to help us go along the process. So how many of you learned basic math at some point, right? And then you went and learned like calculus at some point, and then they said, this is how you do it, and then like 6 months into the learning of it, they're like, by the way, you can just shortcut it doing this. And then you do it a separate way, right? You remember that in like math class or science class or something like that, right? Shortcuts are how other muscle testing techniques came about. Because how many of you think you can memorize these 3 textbooks that all have professional applied kinesiology data and information and acupuncture meridians and alarm points and whatever, and reactive muscles and nutritional interventions and everything to go along with it, right? And that's overwhelming. So people said, you know what if I don't test every muscle in the body, but I test an arm, and then use a magnet and say, what's that lung doing? Or that lung? Or this lung? This is very poor testing, by the way. I'm just like body positioning wise, like this is crazy. But see, that makes a difference. I used a magnet. I used the south pole of a magnet, which should not cause weakness. And that's fine. But that's not. That's okay, that's good. That's good. And I now start challenging certain body parts. I potentially open up a potential window that I couldn't have seen before. Because now how am I going to test something on her body that tells me about her left temporal lobe, right temporal lobe? What muscle correlates with right temporal lobe activity? Who knows, right? What's your favorite Taylor Swift song?
I don't know.
Okay. What's your favorite Bowling for Soup song? I don't know. Pick a song and
Pick a
sing
song
it.
and sing it.
Song that you like though, not like Twinkle Twinkle Little Star.
No, because that was literally the first song that
I
came
know,
to my
but
brain.
you don't require thought for something like that because you can do it by rote.
Hey, hey, hey. I don't know.
I don't know song. What's the song, Liz?
Paper, what did you say?
I was gonna say picture your brain. I don't really know like lyrics. If
Okay,
there's
in
not,
that case,
if
start
it's not
humming.
like
Hum 1985 from Bowling for
You
Soup.
belong with me.
Hmm?
Sing You Belong With Me.
Okay, I need someone to start it off or my brain's not gonna work.
You belong with me.
Okay, start going. You gotta hum it out loud for everybody else. Okay, so we tried activating right brain, but that didn't work. Right? That was the only purpose of that whole thing was how are we gonna try and come up with a way to activate right brain? Music, humming, singing, something like that could be right brain driven, and it didn't work. But if I take this right here, she just goes weak. So something goes on here that she can't handle, but I have no way to physically activate this that I'm aware of. With your eyes only, look just this way, just your eyes. Look to the right, as far to the right as you can, and hold. Look far to the left as you can. Hold. Nope. Look up and to the right. So eye movements aren't doing it. You know, we're just looking for things to try and stimulate to get this to wake up. And it's still asleep. No, it's just not working, right? When I took a magnet, I used the provocation side, which is the south pole, not the global weakness side, which is the north pole. I'm now saying, is this a stressful thing to you? Push up. And everybody says, that is a stressful thing to me. If I go to this part right here with the lung, push up. It says, well, that's not stressful. If I come over to this part, push up. Okay, that's a little bit stressful. Back here, push up. That's stressful. And I should start finding out about her by provoking her body and testing a general thing. The hard part about this is it's very non-specific because I don't technically know that that's a lung thing. I'm just thinking out loud as if that's a body part I might be over. But what if she has something going on here I need to deal with and I'm using a general test? That's hard. So I often default in my initial assessments to standard, systemic, reproducible evaluations. I put things on tongues to see how their body neurologically reacts. And then I ease in after that and I say, well, I wonder what this magnet test is going to do to you. Okay, your magnet tests are causing what I need to happen. That's good. I wonder how else I can provoke your body in different ways to see what else is going on with you so I can make more into this clinical picture. Does that make sense? Kind of, or did I lose everybody?
So you do that like after your initial, like
I
this
do
is
that after
as-
my initial visit.
like
I have
as-
friends
as
that
you
don't.
work- Oh, okay.
Right. I have friends that walk in and they say, how's it going? Nice to meet you. Sit down and give me an arm. And they just do what they do, right?
Mhm.
That's not how my brain works personally. My brain works as do my history, do my exam, do my questionnaire, lay down, let me palpate on you, let me do my range of motion, let me do all my stuff. Everything we learned before lunch is what I do on every patient first visit at least.
Okay.
What you also want to do with Mitch is what I do with most people, most visits after that.
Mhm.
But I will tweak in and add more stuff that might involve magnets, that might involve these things called Riddler points,
Mhm.
which are points along the acupuncture meridian system that might tie into certain body parts, which for most of us is just superficial to the organ we want to look at, right? So I can take an arm, and I can say push up, and she's more or less strong. I can check it and see does it feel weak when I ask it to be. Yes, it does. I can flip my magnet over to provoking. I can say, well, what's that reflex do? What's that reflex do? What's this one do? And when I find one that goes weak, as I'm running through my little organizational structure of points, then I'm like, oh, okay, that goes weak. So a Rife machine specifically is something that is, you can change the frequency of it and try and get that frequency to resonate or harmonize better with the cell that they're interacting with to create change. The theory being either to like high frequency microcurrent is a concept of using that sometimes, or rifle machines, or lasers. You can change the frequencies and mess with stuff. There's different ways of trying to do it, but could potentially have value there. Alright. So going back to some of these points. It's possible that as you go through this rabbit hole of manual muscle testing techniques in your future, you'll be exposed to points that are different between systems. Whereas everything we learned before lunch has a very neurologically sound application. Afferent nerves stimulate certain parts of the brain react through ventral horn activity, causing efferent change. It's a very standardized neurologic application to textbook applied kinesiology concepts. Some of these other ones we're entering into are in that energetic world. So when we talk about these points, some people would say, well, no, the gallbladder point's right here. Why are you poking over here? And, some of it is intention based. And so when we think about, let's go back a little bit to this. Goodness gracious. There we go. Manual muscle testing, what it is and what it isn't. Testing with intent and an open mind at the same time goes a long ways. As we get out of neurologic application and more into energetic application. For some individuals, spots may change, not individuals that you're treating. Some practitioners will use certain spots that mean something to them, and then when they talk with their friends, they're like, well, I don't know that spot, tell me about it. And that might help them to learn more places to mess with, but it's an intention-based process. And I know that's kind of a weird idea. I'll attempt to demonstrate it if someone wants to come up here and be a guinea pig for me and sit right here. I'll just show you.
Go Liz.
This is going to be weird though.
Oh, please. That was weird.
This is weird. Everybody on? Press that for me. Good. Press that for me. Why did she go weak?
Because you asked the soul. Never mind.
Why did that cause weakness? It was a systemic test. It was our systemic approach. Push up again. Now you're backwards.
Yeah.
What happened?
Positive, negative. Other
See, it gets weird.
things.
In some systems, this is the north pole of your palm, and it caused weakness when we started. And some people will use this
This one.
as a way of doing things. Some people would say that the tips matter more than the palm or the back. So therefore, if I'm going through and testing people, I could go and say, how's that going? Versus how's that going? Versus how's that going?
Yeah.
Well, I put south pole on her versus combined poles versus north poles. And that's weird for some people. If I did that to a normal patient when they walked in, they might say, he either was trying to grope me or that was weird, and they may not choose to come back. And I like to have a business that's successful and do things. So I can talk magnets, and I can show papers where people discuss the polarity effect of magnets on different things that have been going back since the 60s. They may not be peer-reviewed double-blind, but at least there's printable material that says when you put the North Pole on things, it seems to attract things. North Pole seems to attract things, and South Pole seems to push through things. And so when they take a bottle or a thing of water that's dirty, and they stick the South Pole of magnets around that, and they watch the water stuff separate and clean out, it's hard to rationalize that in medicine, but we can at least see observable change from something like that. It's hard to see observable change with this. So I don't use my hands whenever I'm doing stuff that's weird. I use devices that take me out of the picture and have standardized rules with it that don't change. North Pole causes weakness. South Pole provokes, and it's like I'm irritating something. I'm driving it into the body. I'm doing something with it, right? So sometimes things like that happen. May I borrow your arm? Say my name is, and then give me your full name.
My name is Elizabeth Taylor.
Why do you not agree with that statement? That's weird. Touch right here for me. Say that again.
My name is Elizabeth Taylor.
There we go.
Emotional.
I would expect somebody to not go weak to their name if they declare who they are, but that's a weird thing. Possibly there's some type of disorganization going on that's preventing her from accepting who she is, or her manifested expression of life, whatever, right? I have no idea. But I can now go into a concept of energetic, emotional something and say that statement again.
My name's Elizabeth Taylor.
And her body says, I'm at least more congruent with that idea. So maybe I need to spend some time figuring out what's going on emotionally in her world. And that's a weird concept for some people. So I don't start there. Plus, personally, I don't like doing it. Remember we talked about the triad of health?
Yeah.
I love nutrition, I love structure, I love neurology, I like things that I can tangibly mess with. I'm not an emotional person, I'm a guy. Like, no, I'm just kidding. No, it's just not something I've ever really enjoyed doing. I do it with some people, especially when they're blocked or they're not doing what they need to do. I'm like, man, you're screwed up today, let's go see what's going on. And I'll do it in my emotional way. But most of the time I just refer people out to Dr. Alyssa, who's our specialist in that world. And she does neuro-emotional technique, which is a concept of muscle testing things while looking at emotional stuff at the same time, because some people are more than chemicals and bones. They've got the emotional side that's affecting what's going on in their world. But I don't really do that, and it's harder to teach because it becomes with intent. Right? And how in the world am I going to make a double-blind, peer-reviewed study with someone saying, my name is Elizabeth Taylor going weak, and now proving that I fixed that? Like, that's a hard ask. But it's easier for me to dissect a rat and say, look what happens when I stimulate this muscle here and how it sends that chemical up this way. All right, cool, we got it tracked. We're messing with. Does that make sense? All right, you crushed it. So sometimes as you move into some of these energetic-based things, if you're not present, your results are all over the place. All over the place. And you're just like, that's so weird. Why in the world did this thing show up? And you start going down this rabbit hole of fixing their spleen, and then all of a sudden you're like, how did they even get here? They have no symptoms doing this. Their muscles are fine everywhere else. Their lab work looks great. What in the world am I doing way on this rabbit hole? And it's because I'm thinking about baseball and the World Series and whatever, right? So, as you're intentional and present, but yet willing to let the body tell you what's going on, you can be amazed by what you find with individuals. And so we've got some options to help us with that. I like to use things that take me out of it. It's either strong or it isn't. The taste works or it doesn't, right? So I do things that take my brain out of it emotionally and intellectually. I mean, I'm still there intellectually, but... All right, one more thing. We didn't really go into this one at all. There are other ways you can check for systemic inflammatory things. Magnet over the belly should cause weakness. Magnet over like the ear. These are large acupuncture places. How many mammals in the world are capable of doing this? One. This is a neurologic disorganization test for some systems. They'll test an arm, and they'll have you just create opposition through your fingers, not in your life. And if you go weak while doing something only Homo sapiens should be capable of doing, you might be neurologically disorganized. There are other things like kidney reflexes point, like K27 on the chest. Sometimes they'll test a muscle, have you touch those things, and if you go weak, it's like putting two wires together and blowing a circuit in the acupuncture system. So there are systems where sometimes you might look at it and say, oh, well, here's a kidney 27 spot, and they have you touch there and they test the muscle and they're like, oh wow, that's weird, you're messed up. You're like, how did I get messed up? You didn't use a magnet and you didn't do anything else. This is a system for some people. This is a system for some people. This is a system. There's just ways of which we can dive in and say, am I getting the feedback I need from this arm that I'm attempting to use as an evaluation tool? Or this leg, or this QL, or whatever it might be. Too weird? No? Everybody's good so far? Carolyn's going to go home and say, come here, husband, let me see what we got. And he's going to say, what witchcraft did y'all go over there? All right, just joking. All right, so we talked about this. Have an order or a flow. Someone asked me when I use this. I usually use this concept much later in the process of evaluating someone. My very first visit, history, exam, review of labs, whatever, standard neurologic orthopedic palpatory exam, just like we learned everything before lunch. The very last thing I do most of the time is I grab a magnet, I say, let me see your arm real fast. By this point, I've already poked on a bunch of stuff. They stick their arm out, I test it, I put it over their belly, it either works or it doesn't, I write it in my notes, and I go on. Because I've already got a game plan based off of their medical history, their exam, their labs, their whatever. I'm starting them on something and getting the process rolling. They're on that process for a week, 2 weeks, 3 weeks, month, whatever it is between now and the time I see them. They come back in. I notice that they were neurologically disorganized or systemically switched. I want to check that on day, like as soon as they come in. Hey, have a seat. We're going to check some stuff. Kind of like last time. Let me see your arm. Great. Boom. Magnet over the belly button. Now it goes weak. Perfect. They've neurologically calibrated themselves the right way after 2 weeks of dietary supplements and nutritional intervention and the adjustment I gave last time, whatever it might be. They're back to normal. If for some reason they're not, then I want to figure out why. And that's the very next thing I do. And it's very early in the patient management process because this is a big deal to me in my hierarchy of fun, right? So if someone ever comes in and I've started them on a process and by week 2, they are not going weak when they need to on a systemic test, I'm going to dig through and find out how and why. Cam, in my room, there are a bunch of like yellow boxes. Go get those and bring them to me, please. And the way I will do that is I will use energetic files to help me recalibrate systemic activity. They will sit down. I will test their arm. I will challenge with the magnet, and it doesn't go weak like it should. Yes, ma'am. I will then have them hold things while I'm testing them against them. So can I borrow somebody?
What brand is
These are the Leibowitz files.
Leadwood?
Leibowitz.
Leibowitz.
Michael Leibowitz
Yeah.
created this system here. There are a bunch of different types of things like this. In there, under this, on like the third shelf, second shelf from the top, there's little VHS cassette tapes. Get the one on the far left, please. So, we have an arm. Push up. She's strong. North pole of a magnet, push up. Been working today? Did that work earlier? Push up.
I did for one person and not for another.
Yeah, I can't
Oh, and you
Interesting.
weren't sure.
Alright. I feel like she's not working like she needs to. She should be having weakness there. Thank you. This is another one I use. This is from a brand called Cellcore. And I use this one a lot. Cellcore. Cellcore. They do a lot of like parasite cleanse things and stuff like that. They have a test kit. I'm sorry, what'd you say? Something? Oh, that
Just a detox.
Oh, detox stuff, yeah, a lot of stuff like that. So they have a kit. Leibowitz has a kit. Oops. Freddie Ullin has a kit. There's a bunch of stuff. Ergopathics is the name of a company where you can go find a kit for absolutely anything under the sun. If you want a kit on vaccines necessary to go to West Africa, I'm sure they've got one. And you can test people to those things and say like, what's going on? And do whatever you want with it. But with this, what I want to see is can I reestablish this normal test by her having something with the energetic system, right? So I just grab a couple of vials and I put them up like this and I'm looking to see does the neurologic or the appropriate reflex return to normal? And the answer was no for these 4. Now I'm going to challenge another 4. Push up. There we go. So one of those, you're taking pictures, Liz. I should stand up and do this correctly.
I know. I was just thinking that. I'm like, oh, you're not doing it.
Alright. That makes the weakness come back. So one of these 4 vials appears to be something that allows her to energetically recalibrate to test appropriately. Make sense? Mm-hmm. Except these are poison vials. She shouldn't go weak to these. They're the toxins and the bad guys. So they're not the good guys that are helping her. They're problematic things. So her energetic system appears to recognize that that's not the right one. Push up. That's not the right one. There we go. That one changes her. We'll do this one. Now what I'm going to say here is going to be said very delicately and carefully. Because just because this vial made her test appropriately, does that mean she has this thing in her life? I hope not. It's a virus mix. It's a whole bunch of combination of viruses put into a energetic solution, and her body seems to resonate with this and say, you know what? When I pay attention to this, I can give you good information. But what diagnostic criteria do I have to tell her she has a virus?
None.
What do you mean? She just went weak and tested like I needed her to.
It doesn't tell you the whole story, it just gives you
That is
one
correct.
word.
Do you have a fever? Do you have blood work? Do you have labs right now for me to be able to confirm this? Because if I were being put in front of a court of law and I said she has a virus, how did you know that? Well, her arm went weak when I put the magnet to her belly and she was holding the virus vial. That probably lands me in jail. Does that make sense? 'Cause that's not what we're doing here. We're using a tool to find a data point to try and justify something going on in her world. Because remember, by the time I'm doing this with her, she's already on a nutritional program. I'm already supporting her body based off of what I know about her, neurologically, structurally, nutritionally, whatever it might be. But I've got this test that's lingering that's saying, wait a second, it's not what I need to do, even though she's already doing these good things. And now we found that this vial for virusy related things makes us test better. So in my brain, I start thinking, what can I do to potentially support her body in addition to what I'm already doing that I know is clinically, medically relevant to help her to have this more appropriate reflex through the system. And if there's something there that is justifiable through her history, her questionnaires, her lab tests, or whatever, I now would motivate myself to do that and support it. We're going to get the white box that's in there. It's on the far right side. Thank you. So that's one thing. Let's check some other ones. Push up. That didn't do it. Because it's also possible that we have more than one thing going on, right? So on visit number 2, generally speaking, is when I would check stuff like this. Didn't do it.
Yep.
Yes, please. Push up. Good. So out of all these big guys, only one showed up, and it happens to be the virus one. Now, because of this, let's just pretend that I'm going to actually support and make this work better for her. We saw earlier that I could adjust her. I could have her touch something and it might give a change. I have her put something in her mouth that might give a change. And now we're in this weird world where I'm looking at stuff energetically and just holding this up to her. You don't even have to have me hold it. You could just take all the fun. Push up. Gives us a different reflex. So this is what I'm looking for is weakness. And I have all my good guys. This is essentially my shelf of supplements reflected in small test kit form. So it's Standard Process, Revita, Apex, all these different companies. And let's pretend I wanted to try and support something that helped her and it made sense clinically and relevantly. We know virus cause weakness. I'm going to grab something called Thymex from Standard Process, push up, and it made her strong. Would you give her that?
Maybe.
Why? She's strong. What do we want to happen?
We need to
It
make
created a
We need
change.
weakness. Ah, but wait a second here. I need weakness to happen. And that's not happening. So let's just see if I take virus away and keep Thymex in. Push up. Push up. Didn't work. So it was a good thought, but I need weakness every time to know that it's the normal response. So Thymex, even though I often think of that for viral related stuff, did not do what I needed to do. Let me try something from a different company called Elysium. Now press up. That didn't do it. Try something else like Conjuplex. Where's my Conjuplex, yo? There it is. Conjuplex. There it goes. Push up. Now, take the virus out and I only have Conjuplex here.
She's strong, like a weak.
Why? Why do we want her to go weak every time?
Because you have the
Because it's North Pole over a systemic area. And it's weird, so we can't always hone in on strong versus weak. We need the appropriate response at the appropriate time in the appropriate place. So, magnet is our rule. North Pole over solar plexus should cause weakness. It's not. We went through some provocation vials and we said, okay, vial, virus, makes this test appropriately in the right spot, right place, right time. We found when we added Conjuplex to this, we continue to test appropriately weak at the right place, right time. We took virus away, push up, we still test appropriately weak, right place, right time. So, hold that for me. As of right now, we appear to test like we want. I'm just going to flip the magnet around. Push up. That spot seems okay. That's okay. Right? We're not getting weakness to any of these. Good. Show. I'm just scanning through all the different points that I typically look at, and that one goes weak. Should it go weak there?
No.
South pole over right ovary-ish area cause some level of weakness. Do we know what it is? Maybe it's really the cecal valve. Maybe it's her colon. Maybe it's her spine. Maybe it's her kidney. Maybe it's her throat. Who knows? It's not her throat. Throats don't go there. Right? You know, whatever it is, something happened. My intention is I'm looking at different organs and reproductive system kind of is in that area, and that's kind of what I was leaning toward. But I don't technically know. All I currently know is magnet caused weakness. And I don't think it should because it's the South Pole. So let me come over here and grab something like Simplex F, which is a female-related thing that made that strong. Does that mean I give it to her? Maybe. It at least counteracts what I'm looking at. Flip it around to North Pole, to the belly, what should happen?
Weak.
I'm much more likely to give that to her because it passed 2 of my tests. It turned the reflex on, and it kept my systemic reflex working correctly. What if, hypothetically, if I do this one, let's see what happens. Push up. OptiCren makes that work better. That's a different company. And push up. Doesn't make that work. Would I give that to her? Why? It made the muscle reflex get better.
Systemically, she doesn't.
But systemically it didn't, right? So I can take my emotional baggage out of it and just let the magnet and the arm help me out.
So for the Simplex F, speaking of having to defend yourself and your choices,
Right.
if she had no female complaints or anything, would you'd still be okay with that, or you'd kind of figure out how it would match?
I have to justify in my brain why I would give that to her. Do you ever feel fatigued or tired? Alright, I give it to her. Right? Does that make sense? Like it doesn't have to be because you have like 30-day cycles.
Right.
It could be, but how many people with some level of female hormone imbalance have fatigue or sleep issues, right?
Yeah.
Now, the good news is I will have had her fill out 4 pages of paperwork of just questionnaires, not including the rest of the details about her. And I'll know a lot about her, and you can justify anything with supplements because we all have all kinds of crap going on in our life. But I at least want it to be clinically relevant. So, could fatigue and tiredness be affected by the immune system?
Yeah.
Yeah, definitely could. Could it be possible that she needs Conjuplex and Simplex F or something?
Yeah.
Yeah, maybe. It could be anything, right? We don't know what she needs yet. But it's a tool to help us know and build on what we are looking at through history, through labs, through questionnaires, through everything. And then I take that information and the section that has the most dots in that area for like blood sugar issue, well, I'm probably going to start on blood sugar. But if there's 1 for blood sugar and 1 for thyroid and 1 for ovaries and 6 for cardiovascular, I'm probably going to start with cardiovascular support over these other ones, even though there might have been a symptom here or there about it. Is that going to make sense? Do you want to play with it?
Mm-hmm.
All right.
I've been shopping for vials.
Shopping for vials, right? Yeah, they're so fun to play around with. Let's see. So in my room,
Alyssa has a set.
yeah. So in my room, we'll use this one. In the back left room over there, there's another one that looks like this. There's one in there. And then whoever's in the back room, we'll use this one. I don't know, are Alyssa's color coded? Mine are color coded on top.
Hers is very small. I'm pretty sure she has Leibowitz.
It's definitely Leibowitz. I just don't know if they're in the right place or not. You'll see here that common stressors include food sensitivities, metals, chemicals, infections, things like that. So these are color coded by category. Immune stuff, heavy metals, chemicals, clotting factor and caffeine related stuff, food stuff, other. So when you pull them out, you'll at least kind of know what category you're looking at. Hers are similarly done, it looks like, and she has a little key on top if you want to know what it is. We just want to try and keep them more or less close together. Cool? So, play with it, see what shows up. If something goes weak, in all of our rooms, we should have a box like this. So in my room, this is the box, and it's every supplement that's on my shelf, so it might be a little bit chaotic for some of you. It's supposed to be in semi-category ways, but we keep running out of space, and we just make it up now. This is all hormone stuff coming over here. This is all immune stuff here until you get to the allergy section. These are detox-related stuff, digestion-related stuff, or they get back and forth sometimes. Heart and cardiovascular-related stuff, blood sugar things, inflammation stuff, and you can kind of see anti-inflammation, cardio, digestion, detoxification. But like, I ran out of space with neuro-related ones, so I just know neuro is here. Like, so they're kind of all over the place. Good luck. Try and put them back where you get them from. If not, I'll figure it out by Monday when I start grabbing them, looking for stuff, and it's not where it belongs. But oh, thank you. So we'll have you.
That dang glass.
That's all right. I don't even mind. Oop, I put them in the wrong place. There's already one missing somewhere. Oh, optogram, I put it in the wrong place. So yeah, so there's one of these in my room and one of these in Alyssa's room. If you're in the back room, there's one from Standard Process. It's a wooden box, and all the pills are in alphabetical order.
There's a whole other white kit.
Is there one in Amber's room?
It's in my room right now, but I can.
Oh, okay.
Yeah.
Never mind. Liz will let you borrow hers. Put it back where it goes. Cool? All right. Let's go play with it. See if you can find reflex points that show up. And go from there. Then one thing show up. And then it's okay. We're not textbooks that only follow like one box that says this is what Parkinson's is, and it looks just like this. Sometimes you can have Parkinson's and digestive problems at the same time, or you can have a variety of things going on at one time. So sometimes when working, it gets confusing. You know, you've done your history, you've done your questionnaires, you've done your labs, you've looked at them, you've muscle tested stuff, you've got all this data, but there's nothing really just jumping out like a smoking gun that says I need to start here. Sometimes I will use hand modes or like sign language for the body while muscle testing. And I like this one a lot, so I like to teach this one first. And it's just doing that. Just put in your middle finger in the inside digit of your thumb. Okay? And it's essentially an intuitive, I'll say made up, but I don't mean it in a bad way. It's the system that someone created that says, this means what's the most important thing. And enough people have bought into the idea that this is a concept commonly used, and it's a system. It's like one of these Riddler points. They might change in different areas. Some people might use a different priority, whatever. But it's a way that you can say in your mind, I need the most important thing to come up on display with our muscle testing so that I can get a little bit more data here. Hey patient, will you do this for me? Or I'll do it myself, one or the other. And I'll test something, and I'll cross-check a couple things. So let's pretend iron shows up and lead shows up. And I need to figure out which one is most important. To be fair, I probably wouldn't ask this. I just detox both or I do whatever. But let's just pretend I needed to have that clarification. I might do the point and then check systemic changes. And then by switching out the vial over and over again, one will show up and one won't. And it'll just be your body saying, hey, this is the thing that seems to be most important to me right now. And the test will shift and not be what it was before. And that kind of sounds weird from a concept. Let's just try it real fast though. Someone come and have a seat right here for me. Anybody, it doesn't matter.
Jeremy.
Alright, Jeremy. Good. We lost my magnets, I put them all away. I'll be right back.
So we've gathered here today to talk to you about this problem. Just kidding.
Alright, you borrow your arm? Press up for me. Good and strong. Magnet, press up. Goes weak like I want it to. Press up. We're testable. This is great. That's what I want to happen. I'm just going to find some spots here. Press up. Rub the back of your mouth with your tongue. like you're tickling your soft palate. There you go. Just keep doing that for me. Keep your elbow straight. Try it again. Rub the back of your mouth. Okay. Don't rub the back of your mouth. Push up. Okay. Rub the back of your mouth. Hold. Good. Rub the back of your mouth. Alright, we're finding a bunch of things. Now that was weird. And I never talk about rubbing the back of your mouth. Involuntarily speaking, we have two parts of our nervous system. Our sympathetic, parasympathetic tone. Our sympathetic tone and our parasympathetic tone. Sympathetic revs things up, fight or flight. Parasympathetic calms things down, rest, digest, feed, breed, heal. The largest nerve in the parasympathetic system is the vagus nerve. The vagus nerve controls soft palate sensation in the body. So when I have him tickle his soft palate, I'm inadvertently activating parasympathetic tone to things. And I said, all right, let's just wake up the parasympathetic nerve, and now let me go check a bunch of reflexes. We're just trying to dig something out and say, maybe a student in Try 2 is slightly fight or flight dominant and less parasympathetic dominant. Maybe. So you activate, rub the back of your mouth. We found that reflex, keep rubbing the back of your mouth. And we're finding a bunch of these reflexes are showing up. Does that mean he really has a lung, a spleen, a pancreas, a gallbladder, liver, gallbladder, and small intestine reflex all off? I'd hope not. That would be really uncomfortable in life. So we can now ask, if we're stimulating parasympathetic activity and we're in priority hand mode, do one of these stick out as something I might need to focus more on? Not more on, but more on. Rub the back of your mouth, Michelle. Guess what? They all went away. Because if I said, there's really not a priority here. Keep it over the back of your mouth. Anybody want to guess where the priority is?
His vagus nerve.
I would say his brainstem. His vagus nerve, where things originate and tell his body to calm down. But we had to activate it to find other weird things, and that's when it showed up. Go and relax there. You don't have to do that anymore. So sometimes if things are looking weird because you're testing people and you're like, this just seems weird, have them put it in a priority hand mode and go back and recheck some of the stuff that you're doing and see if the picture kind of clears up from the static a little bit. Okay? That work? You're going to make it. It's just try to.
It's just true.
It's just.
All right, so we covered a lot of little concepts that hopefully give a bigger picture to the patient presentation when you're interacting with them. We had this kind of conversation a couple of times in the rooms, but I just want to kind of summarize the experience. A patient walks into my office, the way my brain works is I'm going to do a history on them. I'm going to fill out a bunch of paperwork, they're going to fill out a bunch of paperwork, and I'm going to review that with them. I'm then going to do a standard exam of what I think a standard exam looks like. I usually check blood pressure, I will listen to heart, I will listen to belly, I will palpate, just like we talked about today. I will give the patient the experience that they expect to get at a doctor's office, because I want them to be able to connect with what we're doing. Through that experience, if there are more labs or tests that need to be done, I will request them. And I'll say, I'll see you in a week, go get these tests done, and then come back and I'll look over those tests with you. And at the same time, track your food or do whatever thing I need to do with you. Do these stretches, go exercise as much, whatever. They come back in a week later. Before they leave, I will check for systemic blocking or switching. And all that's done on visit number 1, 40 minutes worth of time with me in the office. Visit number 2 is usually about 40 minutes worth of time, where I'm presenting what we're about to do. Hey, based off of your labs, based off of your history, based on your questionnaires, based off of our exam, this is what we're going to do to you. But let me see your arm real fast. See how this test isn't doing what I need it to do? I just need to see how I can get that to change in addition to what we're doing already. I do some testing, I give them a supplement, either on their tongue or holding it, depending on how comfortable I feel with the person, and I find whatever gets them to not be systemically switched anymore. And I say, congratulations, do this. Avoid eating these things that taste good, take these supplements, do these exercises, we'll see you in 2 weeks, or 1 week, depending on what's going on, right? They come back in. They sit on the table. I pull out their supplement sheet of things they've been taking. I check to see if they're testing the way I want them to. They are. I then pull every supplement that they're currently taking and I test them to that to make sure they're still going weak systemically the way I want them to. And if I find one that stops testing the way I want them to, I potentially move that out and I have to rationalize in my brain, is it justifiable to me to keep them on this one product based off of everything we know about them since it makes this test not work right? Or is it okay with me taking this product out of their life because it's not testing right and they're still going to get the clinical benefit I need? And I have to make that clinical judgment, even though it might make them blocked or switched. If it blocks or switches them, I might have to pull something and add it in to make sure they can still tolerate that to get the clinical outcome I need. If they don't need that, I'll take it out and say, great, finish up this bottle, keep doing these other ones. You're testing like I want, assuming they're going in the right direction. Let's pretend they come in 2 weeks later and they're like, I'm avoiding gluten, I'm eating no carbs, I'm facing east, I'm saying my prayers, I'm doing whatever I need to do, right? Whatever you ask me to do. And I'm taking your supplements, and this got better, but these things did not. In those things that did not get better, I pull out the south pole of my magnet and I go check areas that matter. And I say, okay, I already know clinically what should be happening. And you're already on the right program that should be getting you better. Maybe there's something gumming up the process. And I find liver goes weak, hypothetically. Then I take my stressor vials. I'm like, all right, what seems to be making the liver not work right? Oh, copper. That's weird. How can I get liver, copper, and everything to resonate more appropriately? Oh wow, we found GI Adsorb, zeolite. It's like a binder. It grabs onto stuff and pulls metals out, right? So I add GI Adsorb back into their regular program, and now they're testing well again. I say, great, we're gonna make a slight tweak. Based off of what wasn't getting better, we're staying on what we were doing. We're still avoiding things that taste good. You're still taking the same supplements, but I'm gonna add this one thing, or these 3 things, or whatever I need to add in, to try and help these symptoms that weren't improving yet. And it's the game of trying to figure out how to make that person get the symptomatic expression that they want in life again. Right? Symptom-free, pain-free, energy-free, skin-free, sleep-free, sex good, whatever it might be, right? We get that balanced out. And we course correct as necessary, letting muscle testing augment what our real physical exam is doing. Does that kind of make sense? Mm-hmm. That's how I practice, and that's how we use these things, and hopefully you feel comfortable enough to go home and play around with it. You got a group of people you can play with, a group of people you can play with, husbands and people you can play with, things you can mess with. Try it out. You will get better the more you do it, just like riding a bike, just like brain surgery, just like piano, whatever the hobbies are that you have. You'll get better the more you do them. And today, when you first started, it might have been clunky to muscle test somebody. And hopefully by the end of the day, it was less clunky. And in a year, it'll be much less clunky. It just takes time and practice. So be okay with messing up. Be okay to have the grace with yourself to say, you know what, I suck at this, but I'm going to get better. And it's fine. We'll go from there, okay? Any questions before we conclude?
What was the north and south on the hand?
North is usually the palm,
Okay.
south is usually the back, but that's weird. No, I'm just joking. Some people do that. I don't really do that a lot in practice, but some people, that's how they start their techniques. Cool? Thank y'all for coming. Hopefully you enjoyed. Have a good time. Sorry if I went too long and talked too much or made you a bunch of confused people.
As far as magnets go, do you, there's some magnets that you recommend, or do they have to be a certain?
Maybe at least 6,000 gallons. That seems to be the minimum.
So there's,
And so